So,
Hello.
audible.
Very low voice. Increase the volume.
Oh, okay.
Voice is low.
Voice coming or not?
It's coming, but it's quite low.
Very quite low.
Speak loudly. More louder.
I got it. Now check it. Okay. Hello.
It is okay. If it is louder, little louder, it is better.
Okay, let's try. No problem.
Okay. That time when you're speaking, you speak louder. That's all.
Okay. In case any issue, you tell. No problem.
Yeah. You want to share and check once?
What?
Do you want to share and check once?
Which one?
Your slides, do you want to share and check once?
No problem. How I will go share screen.
Okay.
Coming.
Yes, it started. Yeah, it's moving.
Okay.
Yeah, everything is fine.
Okay, fine. Thank you.
Yeah. Stop share.
Sharing stop करना है.
ठीक है, stopped.
Nothing needed, right? ये कितना slide है?
What?
किसका slide है?
Huh?
आपका slide है?
Huh. This is introduction slides. Yes.
Hi, Akshita. Hello, everyone.
Hi, ma'am. Thank you.
Hi. Akshita, since I'm the first one to start it,
Yes,
before me, whether anyone would be introducing?
yes, ma'am.
You would be?
I will start. Yes, ma'am. I'll just give a brief introduction about this, and then I will introduce you, ma'am.
Okay,
Yes, ma'am.
got it. Okay, sure. Thank you.
Yes, ma'am. Thank you.
We are always waiting.
Hi, Dr. Surabhi. Hi, Dr. Akshita.
Hi.
Hi, ma'am.
Hi, it's Madhu. I was wondering, कौन hi बोल रहा है? I could not
आवाज से
recognize the
पहचाने
voice
का.
of अभी पहचान रहे. Now I can make out who is it. थोड़ा एक दो sentences लगता है ना.
I know.
How are you people?
All good. How are you?
I'm good, dear.
Ma'am, anyone wants to check their slides or anything?
Okay, I'll do that.
Yes. I'll stop share.
Screen. दिख रहा है.
Yes, ma'am.
No problem.
Everything is. I'll start in 3 minutes, ma'am. I will just give a brief introduction, then introduce ma'am. Ma'am, and then first there is a debate, like poll. Before the debate, there will be a poll. All the polls I will run on Mentimeter. That instructions I'll give, and I will share the screen that time for the pre-debate. Then post-debate, we have a poll, ma'am.
Sure.
After the pre-debate poll, do I need to speak again and invite the speaker, or automatically you will start?
Ma'am, like you can introduce the speaker first, and then I will announce that I will put the debate, which would be better. Anything is fine for me.
So what I'll do is I'll introduce the topic and the speakers, and then you conduct the poll. After the poll is over, you tell me that now the poll is over, and anyways, I've introduced you earlier, so you
Yes.
can start with the.
Yes, yes, ma'am. Thank you.
You are the first speaker, na?
Yes, ma'am.
So after the poll, just start with your presentation.
Yes, yes.
Okay, sure. Thank you.
Thank you.
I love the profile pic of Dr. Arun Joshi. सब मोह माया है.
Hello, everyone. A warm welcome to all the viewers and the subscribers to the brand new edition of the much anticipated debate series, that is the Controversies in ID Dobara. So this is a platform where ID specialists debate and discuss and dive into the hottest topics in the field of ID. This time we bring in more newer and more provocative topics, and we have esteemed panelists ready to spark insightful conversations. So we have a line of 5 debates currently, featuring the most enthusiastic speakers. Each debate will be moderated by a distinguished expert who will ensure balanced discussion and who will be guiding us through the complexities of each topic. So with that, let's dive. So these are the topics which are there for today. So each one will be of 30 minutes, which will comprise of 10 minutes of for the topic, 10 minutes against the topic, and then we'll have 5 minutes each of the rebuttal, and we will have a pre and post debate polling. So the polling will be done on the Mentimeter. I request all of you to join. You can scan this link to access the poll. Even if you can't join currently, each of the poll will have this QR code through which you can join the poll. So with that, I would like to take this opportunity to invite the first moderator, Dr. Surbi Madan ma'am. Ma'am is MD and fellow in infectious diseases and is the senior infectious disease consultant at SIMS Hospital, Ahmedabad. Over to you, ma'am.
A very good evening to all of you, and thank you, Akshata, for having me here. So we will start with our first debate. And I think it's one of the topics which really needs to be debated, and we see doctors debating in real life on this. So the two glycopeptides, vancomycin and teicoplanin, which one is better? So we have two speakers. Our first speaker is Dr. Akshata R, who is MD DNB and DM infectious diseases. She has also done her observership in transplant ID, and she is a student ambassador from Royal Society of Tropical Medicine and Hygiene. And I'm proud to announce that she's the Young European Society of Pediatric Infectious Diseases country representative. Proud of you, Akshata. So she will be speaking for vancomycin, and then we'll have 10 minutes of talk on teicoplanin by Dr. Madhumita R. Dr. Madhumita is DNB General Medicine and FNB Infectious Diseases from Apollo Chennai, FIDSA. She also has done Tropical Medicine and Travelers Health course, and she has done an MBA in Hospital and Healthcare System. And she at present is working as Senior Consultant Infectious Diseases and Infection Control at MGM Healthcare Chennai. So I think the audience has started the poll. So this is the pre-debate poll happening. Very interesting. Madhu, you are already having your votes here. Let's see whether Akshata can change the post-debate poll.
Yes. So, I request participants to kindly join and do the polling. And I'm really sorry for my voice.
Do we get a notification or an alarm once the polling is over, or we'll have to stop on our own?
Ma'am, we will start, ma'am. Yes. I will just...
Yeah. I think Dr. Akshata, you can start speaking for vancomycin.
Yes.
Over to you, Akshata.
Thank you. So as I could see, so the polls were totally against me, and please excuse me for my voice today. So I'll be talking for vancomycin in gram-positive infection for vancomycin. So we'll start with a case. We have an 83-year-old male who presented to us with fever and altered sensorium for past 4 to 5 days. He has recent history of left femur orthopedic implant, which was placed for a femur fracture. On examination, he has neck rigidity, left basal crepitation, and local collection in the left thigh. So it is obviously some disseminated infection. And the usual investigation revealed neutrophilic leukocytosis, and the two blood cultures flagged gram-positive cocci. And the left thigh USG is suggestive of an collection, that is likely an abscess. So what would be the empiric therapy for this patient? What would you like to start in this patient? What are you suspecting and what would you like to start? So let's see if anyone is responding in the chat. So obviously gram-positive cocci, what comes to our mind first in such a disseminated situation with an implant in place and Likely abscess is most commonly or staph aureus. So the most most common empiric choice, which I can see chat in the chat, is vancomycin. So that again gives towards my talk. So what is vancomycin? It's a first glycopeptide antibiotic. It was discovered by in the Streptomyces orientalis, and it was introduced in 1950s, and it is still in use more than 65 years, and it is still in use, and it was called the Mississippi blood mud. So mechanism of action, it inhibits basically transportation as well as transglycolation, and it is majorly active against your gram-positive. Most of the gram-positive cocci, staph, cons, streptococcus, gram-positive bacilli, listeria, even acting on corynebacteriums and gram-positive anaerobes. And there are various formulation which is available from IV, oral, and because it has no penetration, oral absorption, so it is given as oral, especially C. diff. Then you have intraperitoneal, intrathecal, intraauricular, and IM is quite painful, so it is usually avoided. And when you look at the PKPD, bioavailability, as I mentioned, is not applicable. It has a protein binding of 10 to 80%, whereas teicoplanin has good protein binding, and hence the T half of vancomycin is shorter, whereas T half of teicoplanin is longer. So the dosing of vancomycin is quite standardized, and usually we give a loading dose of 25 to 30 mg per kg for severe infection, including bacteremia, pneumonia, aseptic arthritis. And for the further dosing or the maintenance dose, usually you have to do the TDM. That is, you have to maintain the AUC by MIC of 400 to 600 mg per hour per liter. And the PKPD parameter of interest or which is of concern is AUC by MIC, and this takes into account when the MIC of the vancomycin is 1. And talking about that for the topic for vancomycin, first is established efficacy. Since more than 65 years, it has been used and it has been the gold standard. In any guidelines you open, the drug of choice for MRSA is your vancomycin. And it is well documented and well backed up by the extensive clinical experience. And even now, we have more than 97% of your staph aureus which is susceptible to vancomycin. Then even this is a recent study which was done on comparison of mortality and clinical failure rates between vanco and teicoplanin in staph aureus pneumonia, which was associated by vanco was associated with much better clinical cure and a very low rate of clinical failure, as low as 25% when compared to say 60% in the teicoplanin. Next, talking about the penetration into the infected tissues, it has excellent tissue penetration, including in cases of severe infections like bacteremia, endocarditis, osteomyelitis, and it has good penetration in the inflamed meninges. So this would be crucial in treating deep-seated infections. Then coming to the cost effectiveness, vancomycin is available at a much lower cost. One is availability, it is available in all the hospitals, it is available at much lower cost. And if my component, he will be talking about the various the monitoring and the lab test which is required because you are giving for more doses. Even when you include all the factors, vancomycin is much cost effective, which is especially preferred in resource limited situations, countries like ours. So what do the guidelines say? When you open the IDSA guidelines, there is no mention of teicoplanin. Yes, it is not available in the US market because of the black box warning by the FDA for the thrombocytopenia. So what about Europe? Europe, it has been used. So this is the recent guidelines for treatment of MRSA in the UK. And if you see, yes, there is mention of teicoplanin in few situations, but if you see the severe infections like bacteremia, the first choice is vancomycin. Necrotizing pneumonia, again vancomycin or linezolid. Then meningitis, vancomycin to be given, and they also have a warning about teicoplanin should not be used. Then in bone and joint infection, though they recommend any of the glycopeptides, they mention about the TDM even for the use of teicoplanin. And it has been vancomycin, so it has a proven track record in critically ill patients, and it is extensively studied and well-established dosing protocols are available. And as we all know, in critically ill patient, the patient will have altered plasma protein binding. There will be hypoalbuminemia. So in these patients, the free fraction of teicoplanin will be higher, almost double, and will have higher elimination rate. So do you think it will act in these such critically ill patients? So talking about teicoplanin, whereas vancomycin is more bactericidal, it's a bacteriostatic glycopeptide. It has less efficacy data. It has variable efficacy, and this efficacy depends upon the type of pathogen, the site of infection. So if I tell so there are, especially in cons, teicoplanin has lower efficacy compared to that of vancomycin, and teicoplanin is in general more expensive, and it has reduced tissue penetration in endocarditis, and it has almost poor penetration into the CNS. And there is resistance to Staph aureus has been reported during the therapy of endocarditis, though the mechanism is not sure. Then and it is highly protein bound. So can we actually use such a drug, and can we wait for the concentration to be achieved by in a critically ill patient? And albumin levels are variable, and hence the free levels are unpredictable. And if we give a higher dose, though the side effects are lesser in teicoplanin, but higher the doses, more drug rashes have been reported. And the doses depends on the type of infection, patient factors, etc. And as I've said before, the Goldstein et al. Showed that teicoplanin is less effective than vancomycin against cons and is most resistant in Staph hemolyticus, which is the most common one which we see. So this is the dosing regimen of teicoplanin. Again, this is based on the type of infection and also one more thing we should consider is the weight of the patient. And again, the dilemma is whether to use the actual body weight or the ideal body weight. And also when we give a doses or the loading dose as per these, even then there is data which is suggesting that it is insufficient to achieve 10 mg per liter, which is the target Cmin. Even in 50% of the patient, it was not achieved. Then so in critically ill patients, the standard doses will be under therapeutic. So there have been multiple studies trying to adapt the doses or increase the doses. And in such a situation, we require tedium even in case of teicoplanin. Then this is a retrospective study which emphasized the teicoplanin. So they had two groups of patients. So one of the argument may be that teicoplanin you need not dose it so frequently. So, but this is a study which has compared the maintenance therapy of teicoplanin 6 mg per day and 6 mg Q12 hourly. There was a better outcome, clinical outcome, when higher maintenance therapy dosing was used, and it was statistically significant. So this point showing that whether it is achieving the levels. And second thing is the increase doses. So you have to give higher dosage and you have to give more frequent doses. So we come back to the square one. So why not use only vancomycin? So these are my points. So it has well established efficacy, extensive clinical experience, cost effective, it is available, it has always been the first line of choice for MRSA. There is established protocol, even though there is more side effects, that is the nephrotoxicity, there is established tedium to minimize the toxicity and enhance the safety. There is multiple formulation available, it is effective against critically ill and severe infection, and it has always been everywhere the patients who are empirically been started on vancomycin rather than teicoplanin, and especially in certain special situations like CNS and infective endocarditis, definitely one would like to use vancomycin and not teicoplanin. So I rest my case here.
Thanks out, Dr. That was very good. I invite Madhumita to speak for teicoplanin.
Is my screen visible?
Yes, ma'am.
Okay.
Can you put it in slide?
I'll put it on slide mode. Yeah. Okay, Akshata, congratulations first on your second edition of Controversies in ID. I hope these conversations continue to inspire and enlighten the community. And I'm looking forward to another round of insightful debates. Well, after your vancomycin talk, it might appear the champ in the corner, but let's not forget, sometimes it's the quiet contenders like teicoplanin that pack the real punch. Now, let me tell you why this underdog just might steal the show. So, Teicoplanin for GPCs. About the GPC, glycopeptide antibiotics, we are fighting between the first generation antibiotics. We've not even reached the second generation. So the two brothers are fighting here, Vanc and Teicoplanin. Well, like Akshita said, this was an antibiotic, which was actually the last resort antibiotic discovered way back in 1950 by the Eli Lilly and co. And it continues to remain an integral part in the treatment of GPCs. But there has always been these little issues with the popularity, given the red man syndrome, the infusion-related reactions and the ototoxicity. And that is the reason why they received this name as Mississippi mud, because it was an impure, compound that was initially used, and that caused the red man syndrome, but then they purified it. Still, there are a lot of skin reactions and hypotensions because of vancomycin, even after purifying right now. It has a short half-life, which Akshita very clearly explained in all her tables, but it does have a poor tissue penetration because of the low protein, she showed you about the tissue binding, tissue permeability, poor protein binding. So the tissue penetration is poor. And in the years, about 50 years later, 2003 to 2013, there have been a lot of clinical failures with vancomycin because of the MIC creep. And so people started searching for a new antibiotic. Well, the US did not like a new version or a new antibiotic, so they continued to use vancomycin, and vancomycin continues to be in all of their guidelines. But the Europeans and Japanese thought of bringing a new antibiotic, which was a little less toxic. So we're in about 1989 in Europe and 1998 in Japan, Teicoplanin was introduced. And another reason, this is again from a US paper published in 2013, which is 10 years back, where they said it was time to replace vancomycin in treatment of methicillin-resistant Staph aureus. They did change their susceptibility, the CLSI changed their MIC values from 4 to 2 because they felt that, because of this MIC creep, and there were a lot of hetero-resistant, vancomycin-resistant Staph aureus, or your H visa and vancomycin intermediate Staph aureus, all that. And then the experts started giving recommendation of aggressive dosing, and they started looking into the MIC, defining them by the AUC by MIC, and then they wanted to achieve somewhere between 400 to 600. You cannot be keeping on monitoring an MIC, by AUC by MIC. So they continued to monitor by trough levels, reaching a trough level of 15 to 20, which meant that you had to increase the dose of vancomycin, sometimes up to 2 grams twice a day also in heavy patients. It all increased your nephrotoxicity. And so did this new molecule, Teicoplanin, came into use, which is again a semi-synthetic derivative of a natural product of a bacterium called Actinoplenis teichomycetes. And it is also, it has a broad spectrum of activity against MRSA and VRE. There's not a major change between Vanc and Teicoplanin. These are basically a scaffold of non-ribosomal HEPA peptides, where in vancomycin, it's a 5 aromatic compound, whereas in Teicoplanin, it's a 7 aromatic compound with a lipid chain. So probably that adds to its longer half-life and its more nephroprotective characters. Let's go into comparison. I'm not talking about the dose. Akshita spoke about the dose of Teicoplanin. More than vancomycin, she spoke for Teicoplanin. And so we will look into what studies said about efficacy, comparative efficacy of vancomycin and Teicoplanin. And trust me, most of these studies are from US. though the FDA did not approve Teicoplanin for a lot of cost or pharmaco mafia, I would say, but they've done a lot of studies on Teicoplanin, and this comparative study actually showed no significant difference in all-cause mortality between Teicoplanin and Vancomycin. But however, there were fewer adverse events with Teicoplanin than Vancomycin, including events requiring the discontinuation of treatment, nephrotoxicity, and Redman syndrome. This was in 2009, published in 2009. Couple of years later, in Europe also, they did a meta-analysis of 24 studies where they said there were similar cure rates and microbiological cure along with mortality. The similar mortality, whereas Teicoplanin had lower rates of skin rash, Redman syndrome, and lesser adverse events. And the Teicoplanin also had a reduced risk of nephrotoxicity. So now you're looking into a drug, a brother drug, which has got lesser toxic potential in spite of using in a higher dose. It may be that you need a long couple of doses to achieve a sustained blood levels, but it did reduce your toxicity. And if you look into the other studies comparing treatment for infective endocarditis by MRSA, again, there was no statistical difference in hospital mortality versus and bacteriological failure between vancomycin or Teicoplanin. And this study from US did say that Teicoplanin can be an alternative therapy for MRSA infective endocarditis. Again, looking into bone and joint infections, this study this is from Europe, which said that Teicoplanin may represent an alternative to vancomycin because of its acceptable bone penetration and possible subcutaneous administration. And the last that I have quoted is actually from an Indian consensus, Treatment of MRSA Infections in India, Clinical Insights from Delphi Analysis, which was recently published a couple of years back by Indian authors, Indian ID specialists, who say that Teicoplanin is preferred to vancomycin due to its higher bone levels, lower toxicity, and possibility to convert to OPAT at a later stage. So obviously, a bone and joint infection would require a treatment of, say, probably 4 to 6 weeks or even more. You cannot keep the patient in the hospital, give vancomycin twice a day, he develops a reaction, and then you're spending for his hospital admission, his reactions, which could cause side effects, and probably you could land him up in a dialysis. You're going to pay for the dialysis. If you compare all this, the cost of Teicoplanin is going to be much cheaper, single day use, and he could come as an OPAT to receive the Teicoplanin. And this was study about Teicoplanin use in enterococcus. And this study said that their effectiveness was non-inferiority. And remember, all these studies always said that Teicoplanin is non-inferior to vancomycin. But however, the nephrotoxicity was definitely less in Teicoplanin compared to vancomycin. And an interesting point in enterococcal treatment is if you have a vancomycin-resistant enterococci, if it is VAN-A, yes, vancomycin and Teicoplanin will not work. But if the genetic resistance is due to any other vancomycin genetic type, VAN-B or VAN-C, VAN-D, VAN-E, probably, Teicoplanin did work on it, not probably. Teicoplanin was still sensitive. So you could still use Teicoplanin in a vancomycin-resistant enterococci, except in VAN-A resistance. Okay, and looking into as a neuropathogen, yes, Vanc and Teicoplanin, it can be used in UTI. Remember, MRSA UTI is usually because of a bacteremia or a distant stones. It's not usually a urinary pathogen. So when you use something for a bacteremia, you can always use it in UTI. So where do I use Surely there are enough studies to say that it can be used in endocarditis, osteomyelitis, skin and soft tissue infections, bacteremia in dialysis patients. Definitely, if you're not going to put your patients on vancomycin and worsen their kidney failure and UTI. Well, till today, even I thought vancomycin was the drug of choice in pneumonias, but looking into a couple of papers, and again, this paper, the Indian paper, it did say that teicoplanin is preferred over vancomycin in MRSA pneumonia in view of higher levels in alveolar epithelial fluid. And another thing is that the vancomycin's epithelial lining fluid, the lung epithelial lining fluid level is 1/6 of the serum, and teicoplanin is about 1/3 of the serum. And because of this, teicoplanin could be still preferable over vancomycin in VAP due to MRSA. Okay, why is it not moving? Yeah. So vancomycin versus teicoplanin in MRSA meningitis. Well, this was just an experimental study in mouse, but the experimental study did say that the antibacterial activity of vancomycin and teicoplanin are similar in experimental MRSA meningitis in rabbits. What about human? This is an updated approach to healthcare-associated meningitis. And in this study, they did say that in case of methicillin-resistant Staph aureus meningitis, vancomycin is the mainstay of therapy. But however, linezolid or teicoplanin or daptomycin may be used as an alternative. So it is not that it cannot be used. It can still be used in meningitis. So now where do I use it? Obviously, I could still use it in pneumonia as well as CNS infections, apart from the previously discussed. And ease of use, as already discussed, it has a long half-life. So just a single day injections. And the added advantage is that it could be given intramuscularly also as a single day therapy. And then that reduces your entire cost of hospitalization. And monitoring levels, definitely requires a continuous monitoring level. You need to do TDM, not just to see if you have achieved a proper level. It is also for the toxicity level. But teicoplanin, sometimes you need to do to maintain a target level, not really for the complications or side effects. So in summary, if you look, definitely it has added advantage on pharmacokinetics. It allows a single day use. It can be used intramuscularly. Multiple studies to say that there is lower nephrotoxicity and lower ototoxicity, rare occurrence of Redman syndrome, less frequent TDMs, and there is lower incidence of resistant development. So I'll leave it here.
Dr. Akshita, for the rebuttal, please.
Yes, ma'am. I'll be just sharing my slides. So for the rebuttal, obviously I knew the first point would be the lower nephrotoxicity. Yes, teicoplanin is associated with lower nephrotoxicity, but vancomycin's nephrotoxicity can be easily managed by proper dosing and monitoring. And it is less of an issue when we are using proper dosing protocols incorporating the TDM. And TDM is no longer a luxury, it is a necessity. We need to do TDM for multiple other antibiotics and antifungals. So when we have the facility, it is better to do. And even the recent IDSA mentions, even for teicoplanin, it is recommended. And at least for the vancomycin, the TDM is recommended majorly for the toxicity potential. But as I have mentioned previously, I had showed few studies which showed that the teicoplanin may not attain the level. So you have to do for the therapeutic efficacy as well. Next, less frequent dosing is one of the common. So obviously teicoplanin has an advantage of once daily dosing, which will obviously can lead to suboptimal drug levels. As I've already showed previous two studies, which showed the levels, the maintenance levels was not there were better outcomes if we are giving Q12 tally dosing rather than Q 1 day dosing. Next, better tolerability. Yes, while teicoplanin is better tolerated, Vancomycin's side effect is well known and can be managed, and Redman syndrome, which is common with vancomycin, is due to the dosing, the way we infusion related reaction, which can be easily managed by slowing the infusion rates and pre-medication. And regarding the Cochrane meta-analysis, which showed that it is equally efficacious, one of the things is you should consider is most of these studies excluded kidney failure, and none of them included critically ill patients. So when a patient is coming to you and all the indications which you mentioned, like the osteomyelitis, your pneumonia, then in case of bone and joint infection, etc. So it will, most of the situations will be like a step down therapy rather than giving it upfront. And Teicoplanin, even at higher doses, it has been showed by few studies which may not penetrate the vegetation. So, and regarding the pneumonia, so that was a recent study which I showed, which showed that Teicoplanin was associated with higher clinical failures and better outcomes. So that is what I would rest my case here.
Thank you, Akshata. Dr. Madhumita, yeah, please.
Okay. Hope my screen is visible.
Yes.
Okay. So it's not me, it's everybody who's talking. And the retirement age in India is, I think, right now 60 or 58. So this molecule has been in market for about 65 years. And then people think that it should retire, and especially for Staph aureus endovascular infections. And what they mention is, though it remains susceptible, there has been enough failure with vancomycin high complicated bacteremia. So when your inoculum level in an infective endocarditis is high, they've seen a lot of failures with vancomycin. You increase the dose, you end up with nephrotoxicity. And therapeutic drug monitoring, you have to keep doing that therapeutic drug monitoring. So where is the cost? There is no cost efficacy if you're going to keep doing a therapeutic monitoring, not just to achieve a proper level, but to prevent a toxicity also. So the cost of the therapeutic drug monitoring is much more than the cost of the drug itself. And it is difficult to dose vancomycin in a way that both efficient and safe, especially during long courses of therapy, no IM options. While vancomycin can still have a role, 65 years may be a practical retirement age for vancomycin in highly complex endovascular infection. This is not me who's saying, but it is the paper who is saying that. And did you know that this Actinoplanis teichomycetes was isolated from soil sample collected at Nimodi village in Indore? Okay, so it was found in India, taken over by the Italians and the Japanese to create their molecule, and it's being sold back to India. But pun intended, be Indian, buy Indian. So I would say, to win my case, I say Teicoplanin is from India. So probably I would support Teicoplanin. Thank you.
Okay, thank you, Badhu. Akshata, I think now we'll have a post-debate poll.
Yes, ma'am. Please scan the code and give your opinion. I hope my screen is visible. Okay. Okay, in view of time, ma'am, we can.
Yeah, so that remains a controversy. Nobody can choose whether it's Vanc or Teicoplanin. that's perfectly. You were fighting between two brothers. And yes, there will be a situation where Vanc would be better than Tico, but if you're going to put a patient as an outpatient therapy, you have a better option. So nothing is right or wrong in medicine. Each patient, you have to individualize therapy. And again, don't go back with the home message that Vanc or Tico in pneumonia. Actually, for an MRSA pneumonia, it is linezolid, which is the best. So that was just for the argument's sake. So thank you, Akshita.
Thank you, Akshita and Madhumita. I think you all have presented very nicely, and Madhu has already summarized. Akshita, do you want me to summarize the important points in
Yes,
just
ma'am.
1 minute? Yeah. So, as the audience has polled, both of the antibiotics have got their own niche and their role in specific indications. So, vancomycin has been the gold standard all this while for MRSA. And when the patient presents in sepsis, of course, the first antibiotic which comes to our mind for MRSA is vancomycin. In infective endocarditis and CNS infections, of course, we have more experience with VANC. And yes, the availability of TDM is an advantage over Teicoplanin, and the cost is cheap. So in a patient who is otherwise doing well, in a young patient, doesn't have any major toxicities, and you do the TDM once or twice, then of course it is a cheaper alternative as compared to Teico. However, we are worried definitely about the toxicities when we use Vanco in infections like osteomyelitis and endocarditis, where we use a prolonged treatment. On the other hand, if we see Teicoplanin, it is definitely lesser toxic. It can be used as OPAT therapy, prolonged duration treatments, and better bone and joint penetration. And the only problem is that we don't have the TDMs available freely. And now there is lot of literature coming up which says that we may need to review our Teicoplanin dosing. So it will be better known and better understood once we have the TDMs available. So that's about it. Once again, thank you, Akshata, for having me here. Thank you, Madhumita, for conducting this very nicely. Thank you so much.
Thank you, ma'am. Thank you so much for making time from your busy schedule and agreeing to be part of this. So with that, we move to the next one. So I would like to introduce Dr. Deepak Kumar sir. Sir is Associate Professor in the Division of Infectious Diseases in Department of Medicine in AIMS Jodhpur. So I have been privileged to have trained under sir. So sir, over to you, sir.
Hi, Akshata. All fine here. How are you? So, our next session for the debate is empirical versus preemptive therapy for CMV infection in solid organ transplants. And the speaker for the talk is Dr. Ramaya. Dr. Ramaya is an infectious disease specialist and a senior resident in the Department of Family Medicine at St. John Medical College and Hospital, Bengaluru. And the second speaker is Dr. Santhanam N. Santhanam is assistant professor and infectious disease specialist in Vellamal Medical College, Madurai. So we can start with Dr. Ramaya. Oh, Dr. Sir, you will going to share the pre-debate poll.
Please share your thoughts regarding the topic. Please scan the code to attempt the poll. Sir, we will go ahead with the talk. So 50-50%. Okay.
So we can end the poll. It is 40-60. So we'll see after the talk. Yes, Dr. Ramaya. Dr. Ramaya, you can start. You are not audible.
Yes.
Can you hear me? Am I audible?
Yes, please.
Yeah.
Okay. Akshata, I would like to first congratulate you for all the laurels you have achieved. It will be more than an hour talk, so we'll stick to CMV for today. So CMV is one of the major cause of not just mortality, but severe morbidity, as at least seen in majorly transplant settings, solid organ transplant and hematopoietic stem cell transplant as well. So I have taken this from the systemic literature of the seroprevalence among transplant patients. CMV is more seen in most of the population, say 60 to almost 100% of the population is affected with this. The most common clinical picture in especially transplanted host can anywhere be from a minor viral syndrome, say fever and malaise, and it can end up to leukopenia, thrombocytopenia, elevated liver enzymes. So the symptoms appear somewhere, say, 3rd to 4th week. The symptoms peak by around 6th to 16th week, and it is generally rare after 6th month. So what are the factors that determining the illness, especially in those who are without prophylaxis, is the type of transplantation. So heart transplantation, the incidence of illness is around 9 to 23%. Lung and heart plus lung transplant is 50 to 75%. Pancreas and pancreas plus kidney transplant is around 50% incidence. Liver transplant around 30%. Kidney transplant 8 to 23%. Allogenic stem cell transplant 30%. Yes, even autologous stem cell transplant has 5% risk. So roughly around a solid organ transplant 50 to 60% and 30% in the hematopoietic stem cell transplant. I have taken from the International CMV Symposium 2021 data is what I presented now. So without a preventive strategy, CMV disease typically occurs during the first 3 months after SOT, and this onset has been delayed in transplant patients, whoever has received the prophylaxis. I can stand and list out the number of studies, but I have just put it out for your reference. I'm sure all of us are aware of this. So I would like to briefly compare prophylaxis versus preemptive therapy. So what is the basis that prophylaxis therapy actually works? So I backed up by large randomized control trials. Is preemptive still okay? Maybe, but small trials are there. What is the ease of prophylaxis? It is very easy. Start the medicine, monitor. What is the difficulty in preemptive? More difficult to correlate. Okay, and viral load thresholds are not standardized. But prophylaxis, the thing is, generally we fix a date, day 100, or varies from centers. So late onset CMV is more common. In preemptive, since we are monitoring, maybe less common. Cost, higher drug cost. Preemptive, higher laboratory costs. Toxicity, there could be some myelosuppression. But again, I can argue it saying that if you do not treat CMV, again, there is leukopenia itself. In CMV, viremia itself. And there is less chance of drug toxicity. Now, I'll come to the most important part. The indirect effects like graft loss or graft versus host or graft acceptance, rejection, mortality, opportunistic infections. Yes, there is a positive impact, and there are meta-analysis and also some limited comparative trials that show that prophylaxis is beneficial. However, for this preemptive therapy, whether there is graft loss or mortality or OI, there is not much data yet. Drug resistance, you might argue saying prophylaxis might contribute. However, we'll be surprised to know that even preemptive therapy is not totally free from contributing to drug resistance. I'd not like to go much in detail. I have to restrict myself to 10 minutes. So most commonly we use valganciclovir. But for other drugs like foscarnet or pseudofovir are upfront not recommended for preemptive therapy. So there is concern regarding use of preemptive therapy in especially those with D+ positive patients, especially in solid organ transplants like lung transplant. Excuse me. Solid lung transplants, mainly because of the potential weekly once surveillance to detect the rapid viral replication. So this is a Lancet study that determined the viral load kinetics. So is preemptive therapy really helpful? They actually showed that it could actually be potentially dangerous if you do only weekly once monitoring. So what did they recommend? If it is a D+, especially in a kidney transplant, antiviral prophylaxis is preferred and level of evidence is 1. If it is only R+, maybe you can debate among antiviral prophylaxis or preemptive therapy. If there is a D+ in pancreatic or kidney pancreatic transplant, antiviral prophylaxis is always preferred for 3 months with level 1 evidence. If there is a liver transplant, again, D+ is if there is a D+ patient, antiviral prophylaxis is again preferred. What about heart? Again, if there is D+, antiviral prophylaxis is definitely preferred. For R+, you may debate between the two. If there is a heart, if there is a lung or a heart and lung transplant, if there is intestinal or a tissue graft, composite tissue graft, whenever there is D+, always antiviral prophylaxis is indicated. If there is R+, again, still for these scenarios, again, antiviral prophylaxis is preferred. So before assessing the need for prophylaxis or empiric therapy, we always do our donor, recipient, CMV risk assessment. One of the factors that we generally should also consider is what kind of medications or other associated comorbidities the patient is on. So as we discussed, not just the type of transplant, the other associated comorbidities or whoever is receiving lymphocyte depleting drugs are at very high risk of CMV. So even if they are at any other low risk or a D-, if they are having any associated comorbidity or on use of lymphocyte depleting drugs, they're unfortunately at still very high risk of CMV. What are the diagnostic challenges which are established and what is pending to be explored? Whenever there is a high CMV load, it is associated with a higher invasive disease. And lower value is something called as intermediate viral loads are seen with lower range of CMV syndrome. What needs to be explored is, unfortunately, we cannot label because these syndromes have a very wide overlap. So there's the overlap between these categories. What is established is higher viral loads are generally observed when the donor is positive, okay, compared to the recipient being positive in solid organ transplant patients. What needs to be explored is how high is high? Is there a number? Are the levels standardized for various types of transplants? Liver is a bigger organ, kidney smaller organ, I don't know, some logic. Is there any kind of viremia donor? Is it related like that? The rate of rise in viral load is an equally important marker for CMV risk. The faster the rise, the higher the risk of CMV disease. So in that case, at onset, if you get a higher viral load, say for instance, you're doing your preemptive therapy, you get a higher viral load, does it mean that you should monitor more frequently, twice a week? What is the frequency that needed? So again, vice versa. If the viral load drops after your therapy, what is the adequate time to monitor for level of viremia or level of resistance? After doing your level, if you want to start a drug, will you wait till the next week to look for the response or for resistance? So these are the studies I have backing up for this. So I would like to come to now drawbacks of preemptive therapy. The major drawback is we do not have a standardized test. QNAT has not been standardized. Actually, this was initially not even available in major places where we used to work. But having seen that all of you are from ID background and work in a pretty tertiary care, I would like to know that all of us have this facility, but standardizing the levels is the problem. So the viral load cannot be directly extrapolated from city. So we roughly use a 3-log variation due to differences in platforms compared to the other techniques. So now, assuming there is a patient having a low viremia, especially those with tissue invasive disease like late onset gastrointestinal disease, they all have very low viremia. So they may not be able to detect by whatever test we are having until and unless it's a very standardized test backed up by a microbiologist. So in that case, do we still keep relying on the negative viral load report, or will you target the patient if he is within the first 100 days of transplant? Again, there could be some minor viremias in these kind of cases, compartmentalization or use of less assays, less sensitive assays. So the disadvantages with preemptive are the lab monitoring of QNAT or PP antigenemia assay is not really standardized. The recommended monitoring is once weekly, which I feel is very less. But if you want to do it daily, either it is irrational or you may end up wasting patients' money. The viral load threshold for initiating the preemptive therapy remains very center specific because there is no standardized reporting system. So further studies are needed to decide what is a standard level to start preemptive therapy in our country at least. So for preemptive therapy to be effective, the recipient should be monitored at a regular, at least once a week, to look for either by QNAT or antigenemia. But though most centers, advanced centers, like most of the esteemed guests in our meeting today, though they have the facility to do QNAT, it is still, they still use hybrid approach. As in, they start with prophylaxis and they start using your preemptive therapy only after crossing their 100 days. So only targeting the late onset CMV disease. So first 100 days, most centers still use prophylaxis followed by preemptive therapy, where prophylaxis is never skipped. So one more concern is prevention and treatment in pediatrics. There is very limited data regarding preemptive therapy in pediatric patients. There is also concerning data for oral ganciclovir, but there are other preventive strategies like primary intravenous ganciclovir can be done. Oral ganciclovir for prophylaxis in stable pediatric patients can still be used. The duration of ganciclovir is influenced by the
I
risk.
have to wind up.
Okay. So the duration, there is no single center consensus data for this. So in conclusion, based on the high rates of prevalence, severe morbidity from fever to sepsis or graft rejection, I recommend prophylaxis with antiviral. The choice of the drug is tailored as per the patient. Over to you, Akshata.
Thank you, Dr. Maya. Now, Dr. Santanam.
I'm not able to share.
I'll look into this.
Good evening, table sir.
Good evening. How are you, Santanam? Now you can,
Fine.
yeah,
Okay.
you can start.
First of all, thanks to AIM, Jodhpur and Akshata. Let's I will go to my topic. Dr. Ramya told exhausted topic with prophylaxis. How will go preemptive treatment will go. He told so much guideline, theoretical effect. What is practically we are doing? Let's see. This one case. Sorry. 45-year-old male with a known case of CKD for past 2 years on maintenance dialysis. He went for renal transplant. donor is positive, recipient also positive. No other comorbidity. Let's see what is differing that this patient, this type of patient, what people is differing. Please vote it. I will give 1 minute. Okay, let's see our thoughts, how different ourselves. This is what routinely we are doing. Prophylaxis for only risk factor people. What is definitive? That is proven disease people. What is preemptive and empirical? Preemptive, there is some marker will be some marker or some CMB for CMB PCR, something elevated. For empirical, they have patients have symptoms that patients only need consider. How important for transplant people CMB? There is solid organ transplant and bone marrow transplant. Solid organ transplant always the donor will be big problem. For DMT, there is recipient will be problem. There is primary infection will be common in donor positive people and reactive positive in recipient positive people. There is infections are higher incidence in donor positive people for infections and disease and pneumonia. There is much less in both are positive people and other people comparatively. What is routinely we are doing with the high risk people and medium risk people and low risk people. High risk people, we are doing routinely universal prophylaxis in many centers in renal transplant. But liver transplant, it's totally different. Many centers, they only 30 to 40% people, high risk people itself, they monitoring viral loads because of the toxicity of Teicoplanin. The medium risk people, the renal transplant, the older people are following that one prophylaxis. But many people, they change that now they have adapted to the CMV PCR level. Liver transplant, the maximum 70 to 80% of people in all over the India, they doing preemptive approach because of toxicity and other problem like the way they monitoring CMV PCR. Previously, the speaker told like the problem with PCR DNA, the level it's not quantified or standardized in lab. But what is guideline saying? Don't change the lab. Frequently, whatever you are monitoring the DNA PCR, you go with same lab. Don't change like doctor shopping like you lab shopping. You go for different lab. Lower risk, obviously, you go with monitoring only, not much complicated. Medium risk, 70 to 80% of people are up to PCR level monitoring in liver. Renal, what they're doing is 40 to 50% of people started adopting. The only problem is behavioral changes which their main role. What is BMT? How they overcome CMV disease means we'll go for routinely we are doing preemptive or prophylaxis, but 90% of people, 99% of people are doing for preemptive PCR monitoring. The better chance to prevent CMV disease by prefer donor. For negative CMV negative people, better you go with the donor and recipient. Both recipient is suppose negative, the donor also better prefer negative. Another thing, if you want to transfusion blood, you go for liquid depleted or seronegative donor blood. This resulting following BMT. What guidelines what they doing is acyclovir or valacyclovir they're using. Because of the toxicity of the drug, they routinely 99% of people they not following cancer Valgan or cancer whatever for CMT. CMT of course is for CMT they routinely the following. The problem is solid organ transplant hours. The preemptive versus empirical, the main thing problem, targeted treatment, which patients we need to adapt. Based on the risk factor, we need to go with donor positive or recipient positive, that's a big problem. Another thing is toxicity of the drug is big problem. Another thing is cost. What is Western guideline they telling that is DNA PCR level is not much costly in routinely monitoring compared to the drug level. The drug you are giving routinely. And then minimize the resistance in future and delayed after 100 days, what else we could do. And after 100 days, chances of the reinfection is very high with prophylactic patients. There is a better outcome with preemptive. What is this one for mainly for liver transplant patients? The lowest preemptive versus prophylactic compared. The lowest instance of CMV disease over 12 months. There is initial 12 months where there is prophylactic versus preemptive. Preemptive is better for liver transplant. This one again, the same point what else I am discussed is cost, toxicity, prevention, everything. What is preemptive? The better role the difference is CMV specific immune reconstitution. Here is main point I want to highlight here. Main point is immune reconstitution is the main role in preemptive therapy. This one for meta-analysis in Cochrane, they studied two type of studies. Which studies first initially they involved 288 people. Here the chances of CMV disease is very low with preemptive therapy. Another thing is another 8 studies there is compared preemptive versus prophylactic, no significant difference. Again again here you see the risk ratio is again very low with CMV disease in preemptive people. 0.29, 0.41, like it should be very low. Comparatively, GMP is better than prophylaxis, obviously, according to Cochrane review. Here, another study, there is PMT, here is higher incidence of CM reaction usually prophylactic cases. The study in mainly for prophylaxis of PMT, prophylaxis, the chances of CM reaction is very high. Mainly, this is even they use letimolol prophylaxis, that season also they have higher chances of reaction. Another thing here is you see that liver transplantation same like older again already discussed the lower rate of CMV disease and its cost also compared to prophylaxis is very low. Delayed onset of CMV disease is higher than prophylaxis people. Or already I told what they routinely are following is donor positive, recipient positive. They mainly in kidney transplant what they following is donor positive people, they going high risk people, they going for prophylaxis. But again, PMT is alternative approach in Indian setup. But in donor positive and recipient positive, both are there. Intermediate risk, but we go with both. But liver, you see there are different things. Donor positive and recipient positive, both are there. You will go for preemptive approach in many places. Even 70% of places they going for preemptive approach. The problem is donor positive patients still they adaptation practical difficulties are they need to acceptance is a big problem here. But even 30 to 40% if you can overcome that preemptive approach. Again, other things are the same like that way they following. Pediatric also the same like adults, they routinely following as per guidelines. I will come to the end. What people know how I will defend, like the way you see. Same case, 45-year-old male, CKD on dialysis, donor positive and recipient positive, both are positive. They planning for renal transplant. Patient is no other comorbidity. Let's see what will be better choice. Prophylaxis or preemptive approach. Let's vote it for 1 minute, I will see. Please vote it. Okay, I will give to moderator. Thank you so much. Thank you for opportunity. Thank you, sir.
Thank you, Santanam. It's time to rebuttal, Dr. Amaya.
Yes, sir, I will stop.
Yeah, thank you. Dr. Amaya, are you there?
Yes, sir. Sharing my slide. Just a minute.
Yeah.
Is my slide visible?
Yes.
Okay, that was an extensive review, Dr. Santanam. So I would actually agree with most of the points you put it up. And in most of the times, both of us were speaking about the same thing as to in solid organ transplant, when the donor is positive, maybe the confusion is still there. But one more fantasy, what you mentioned is get a donor who's negative. I would like to point out that that's a little dream. So 60 to 100% of us, most of us are already latent. So my conclusion is, when the donor is positive, I would still recommend prophylaxis. And there is, okay, if you feel that there is no standardized lab, using the same lab, is it okay? First of all, is the lab standardized is my question. I'll use the same lab, but is the level standardized? For me, a 2000 level viremia is okay. For another person, 200 level viremia will ask you to start the drug. Is that okay? So that is why there is no standard level. Lab, I agree with you, but what is the level? So we have to go for a 3 log rise. And one more thing, if at all there is a case of drug resistance, newer drugs like mariberavir have been approved. And one more update is, even letermovir has been shown to be non-inferior to ganciclovir. If you thought that the toxicity and side effects like leukopenia is a concern, shifting to letermovir, which is now available, should also be an acceptable option. So yeah, at least I would like to stand that at least if the donor is positive, prophylaxis for at least first 100 days is definitely needed. Maybe then afterwards we can shift for the preemptive approach to detect the late onset CMV viremia early. So thank you.
Santhanam.
Yes, sir. Same thing I want to tell you. There is a problem with that was lab. You you need to agree, mom, because of we are doing good standardization with the lab in many places. Not the only few places that don't we need to worry. Another thing is another thing I want to do, there is a problem with the toxicity. There is a big problem. The toxicity will be big problem. That's what I'm telling. The many places in liver they started doing with the preemptive approach, not for prophylaxis. In many places, the problem with the renal, there is older people they not accepting that newer things. That's a big problem with the high risk people. There is intermediate risk people. Many people they started doing with preemptive approach. The problem with the high risk patient in renal transplant, there is older people they not started doing because of not acceptance the practical difficulty with the people. Thank you.
Thank you, Santhanam. I think it was a very excellent debate, and I think a very burning topic that what should be used. And Dr. Ramaya has highlighted very important points that there's a high risk of CMV in initial 3 months, and there's a not a standardized CMV PCR test is available, and the cost is for testing as well as the drug are almost equal. But Santhanam has equally highlighted that with the newer advances of the PCR techniques, we can standardize the technique, because most of the center which having doing transplants are quite enough equipped to do the standardization, and definitely excessive exposure of the drug is lead to the resistance and the toxicity. So we have to move on the newer drug which is more costlier than the available therapy as well as the PCR. So I can say in the high risk patient, definitely we can use the prophylaxis, but when intermediate to low risk, according to the patients, we can make it preemptive therapy rather than the always to use prophylaxis. I think it is everything from my side. Thank you very much to Dr. Ramaya, Dr. Santhanam, and especially Dr. Akshata.
Thank you, sir. Thank you for making this session a grand success by your presence. So with that, we move to the next topic. So I would like to invite Dr. Vidya Devarajan. Ma'am is trained FNB ID and is a senior consultant in infectious diseases in Rella Hospital, Chennai. Over to you, ma'am.
Thank you, Dr. Akshata. At the outset, I would say very well done. I mean, it's an absolutely amazing learning session for all of them. Congrats, Dr. Akshata and the entire team who's sitting here on Saturday evening listening to all these and also the speakers. So I'm not going to take too much time. So we have a very, we are delving into or navigating the landscape of gram-negatives after the gram-positive and the viral session. So this is going to be, it's like hotter, hottest, because what you're facing in and out in your practice is challenging gram-negative cases and limitations of clinical efficacies, toxicities of traditional versus newer drugs. So we have two great speakers, Dr. Subhashri Samantare. So she is going to be talking to us about traditional methods for treatment of MDR gram-negatives. Over to you, Dr. Subhashri. Dr. Subhashri is an associate consultant, infectious diseases in Manipal Hospital, Bhubaneswar.
Good evening, ma'am. Good evening, Deepak sir. And thank you, Akshata, for this opportunity, and congratulations for all your achievements, and also for the second session of Controversies in ID. So without further delay, I'll move on to share my screen.
Any problem?
Yeah, I'm just on it. Yeah. Yeah, is my screen visible?
Yes, doctor.
Yes, thank you, ma'am. So coming to the traditional versus newer emerging treatment options for the MDR infections. So I'd like to start with a case who is of a 28-year-old male chronic alcoholic presented with hematemesis melina since 3 days. And on examination, to start with, he was afebrile. And however, he had hypotension, tachycardia, icterus was there, and hepatosplenomegaly was there. He was resuscitated and stabilized in ER, and he has passed repeated hospitalization history for spontaneous bacterial peritonitis and received multiple. The varicose band ligation was done and the patient was discharged. However, he has to be readmitted with the current episode and with a TLC of 18,000 with 94% neutrophil and deranged LFT. So he was started on injection meropenem, Teicoplanin, and in the meantime, we got ascitic fluid culture susceptibility, which showed no growth. However, the TLC was rising and the patient developed one spike of fever. So in the meantime, he was shifted to ICU and the hepatic and renal parameters were worsening. He was intubated and was put on mechanical ventilator. So in this case, would you like to upgrade the antibiotics for this patient? So I'll not wait for the poll. So I'll tell you the exact scenario, actually, what I face today. So in this scenario, we start the patient or upgrade the patient from meropenem to this fancy drug that is Zabicepta, ceftazidime avibactam, or few of them, if they suspect intra-abdominal infections, they'll go for TG cycline. But still, what I'm seeing in my personal experience, the rampantly antibiotic that is being used is the Zabicepta and Astronam combination. So a choice of empiric antibiotics, basically it should be decided upon the clinical syndrome, the previous cultures, the spectrum of antibiotics, the tissue penetration, antibiogram, the safety parameters like how it affects the liver and renal function, and cost and availability at the local site. So then coming to the several definitions, I'm not going to the detail. We are all aware of MDR, XDR, PDR, and difficult to treat definitions. So this is an updated list of WHO priority pathogens, so which includes the carbapenem-resistant Enterobacter and Acinetobacter baumannii, which is carbapenem-resistant as the critical group, and other Pseudomonas aeruginosa, which is carbapenem-resistant at the high group. So we are going to focus on these. So this is again a basic necessity actually before going to the discussion on the MDR infection. So types of beta-lactamase enzymes. So what is more concerning to us is the this class B beta-lactamase, that includes the NDMs, IMP, and WIM. So now coming to the beta-lactamase inhibitor, so based on which these newer treatment options are available to us, that is the avibactam, like in combination with ceftazidime or tazobactam or weborbactam. So as we can see, the MBL coverage of all these beta-lactamase inhibitors are very, very poor. So coming to the CRE or the carbapenem-resistant Enterobacterales, so they are associated with high mortality and is quite common in the Indian ICU setups. There are some strains of hypervirulent Klebsiella pneumoniae strains which actually pose additional threat because of the extra biofilm and also the higher resistance patterns. So coming to the difficult to treat Pseudomonas infections, so the definition is very well given in IDSA AMR guidance. And the preferred antibiotics in the non-critical patients are going to be the non-carbapenem, such as piperacillin, tazobactam, ceftazidime, cefepime, aztreonam, based upon their susceptibility. And also the high-dose extended infusion of carbapenems. And for critically ill patients, the newer options like ceftolozane, tazobactam, ceftazidime, avibactam, and imipenem, cilastatin, relibactam are the options, again based on the availability. But the first thing is based on the susceptibility. So coming to the CRAB, so in Indian scenario, we can use the dual drug or the triple drug combination therapy. So now IDSA AMR 2024 guidance suggests to form a sulbactam-based combination therapy. So which should include at least sulbactam along with polymyxins or minocyclines based on the in vitro susceptibility. So this is IDSA AMR 2023 guidance. So this gives a list of drugs which includes all the traditional as well as the newer options for the treatment of the multi-drug resistant infections. So how to choose empiric treatment of such critically ill patients? So we don't know the bug, whether it's pseudo or acinator or Klebsiella. We don't know the resistance mechanism, and however, we need to select a broad spectrum that will cover all of the above. Now, coming back to the case, the patient's blood culture grew E. coli, which was resistant to everything, including the molecule that is ceftazidime avibactam. And colistin, by disc elution, the colistin MIC was 0.5. So this is in this case, actually, the definitive treatment was started like polymyxin, and because the meropenem MIC was 16, so following the IDSA AMR 2023 guidance, the patient was started on polymyxin B and high dose meropenem, that is 2 grams intravenously 3 times a day over 3-hour extended infusion. So these are few evidences suggestive of polymyxin still effective for CRE. So this was an article that was published in Journal of Antimicrobial Chemotherapy, which summarized most of the studies which showed the polymyxin efficacy against the CRE ranged from around 58% maximum up to 81%. So there are various studies which were conducted which also showed the polymyxins work well on combinations against the KPC producing Klebsiella or in the carbapenemase producers who are MBL producers as well. So these combinations mainly included polymyxin with tigecycline or polymyxin with rifampicin, and very few actually included polymyxin with high-dose meropenem. However, the later studies decided non-superior, this combination therapies were not superior to the monotherapy. So that is why the polymyxins also work well with the monotherapy. So this is one of the study which was published in Lancet Infectious Disease, which showed no significant difference between the colistin monotherapy and combination therapy in treating the multi-drug resistant like CREs as well as the Acinetobacter baumannii infections. So this data has been taken from ICMR 2022 guidance, so which shows in the Klebsiella pneumoniae isolates, the colistin susceptibility was approaching 90 to 100%. And similarly, coming to the prevalence of resistance genes, as we can see, the rise of the NDMs, okay, even though ESBLs are more common, but still we have treatment options. But when it comes to carbapenemases, the NDM, IMP, and WIM are on the rise in the Indian setups compared to the Western countries. So this is the data showing the susceptibility of Pseudomonas isolate. So in this also, the susceptibility of polymyxins and colistines approaches 100%. And this is another list that is also taken from ICMR. So amongst the Pseudomonas aeruginosa isolates, the percentage of WIM and NDM is so much more compared to the KPC, GES, and other carbapenemase enzymes. And similar is the scenario with Acinetobacter baumannii. So what I want to highlight through these data is that the MBL or the metallo-beta-lactamase incidences are so much more in the Indian scenario, making these combinations like ceftazidime, avibactam, ineffective in our case or in the Indian ICUs and in the critically ill patients. So this is a summary actually of a review article. So, for CREs, for carbapenem-resistant Pseudomonas aeruginosa, and even for Acinetobacter baumannii, the polymyxin-based combinations still come as first to our mind or to a consultant when we encounter such critically ill patients. Additional thing is polymyxin B has an anti-biofilm activity, which is lacking there in the ceftazidime avibactam. So that is so now considering the ceftazidime avibactam, even though it was FDA approved in 2015, but still the resistance rate is approaching like 60 to 70% in few of the Indian scenarios. However, the polymyxin B being one of the traditional antibiotics, which was introduced in 1959, still maintains its credibility for management of MDR infection. So I'll still go for a polymyxin B based combination therapy when it comes to a multi-drug resistant infection and the patient was critically ill. So over to my colleague.
Thanks. Thank you, Dr. Subhashri. Thanks a lot. Next, we have Dr. Sneha, who is an infectious disease specialist from Aster Medicity. Over to you, Dr. Sneha.
Hi, I hope I'm audible.
Yeah, you are, doctor. You are.
Okay. I'll just share my PPT. I hope this is visible for everybody.
Yeah, your screen is visible.
Okay. Thank you. Thank you, Akshita, for this opportunity. And yeah, Shubhasri, that was wonderful. But I think we forgot a few newer things. So what are my objectives in this debate? So basically, I'm just going to talk about the CRO GNBs that Dr. Shubhasri was discussing about. And it'll be more towards the novel treatment options, the beta-lactams and beta-lactamase inhibitors, tetracyclines, and aminoglycosides. And I'll be taking you through through various evidences and knowledge. So these are the number of common novel beta-lactams and beta-lactamase and beta-lactam inhibitor combinations that is now presently recommended by even IDSA. So among first, we have the Astronam avibactam combination. So the Astronam avibactam combination as such is right now in trial phase in the European countries. And in our country, we have ceftazidime avibactam used in combination with Astronam. So this is active against all the CREs with metallobeta-lactamase and OXA48-like, as well as a lot of the Pseudomonas and Pseudomonas isolates, which are carbapenem resistant. Now, coming to so there's a huge surveillance study which actually collected a large amount of isolates from various parts of the world that actually showed that Astronam avibactam activity is more than 95% and is preserved in many isolates, including MBL isolates. And also, this is the revisit study, which is the phase 3 study on Astronam avibactam, the molecule, and which was done on complicated intra-abdominal infection, showing a good efficacy and safety pattern for Astronam avibactam metronidazole combination against colistin. Also, next we have cefiderocol. But unfortunately, this is not available in our country. And also, the resistance pattern that we see in our country isolates are unfortunately a little bit more towards the resistant side of cefiderocol. So these are active against MBL OXA48 isolates, but as shown in this study, so against all the carbapenem, but the most isolates that are seen in India are few of the isolates, around 30% are resistant to cefiderocol. Now, but this has a wide action on CRE, pseudo, as well as acineto infections. Now, coming to ceftriaxone tazobactam, which is also, again, which is actually redundant in our country because a lot of our carbapenem-resistant pseudo are MBL producers, and this is mostly active against KPC producers. Now, coming to the next, our own homegrown antibiotic, cefepime-zidibactam, which is led by Wokat, and this is active against the whole spectrum of CRE, CRPA, acineto, and also even few non-fermenters like Burkholderia. So it is actually now used as a compassionate basis in our country. It doesn't yet have a DGCI approval, and it's also in the phase 2 and 3 trials in various hospitals in our country. So it has shown its action against a lot of NDM producing E. coli. So like Subhasri was showing in the previous slide, we have a lot of isolates. I mean, not a lot, not compared to Klebsiella and Pseudomonas. E. coli isolates are lower, but yeah, E. coli has a much higher resistance to Astrazeneca and Avibactam, and in those cases, there is Cefepime-Zidibactam that can be used, and especially it's been used in really difficult to treat situations. And also, also there is this study, which was again a surveillance data collected from around the whole world. A lot of countries have submitted their data, and Cefepime-Zidibactam has retained its sensitivity against a lot of isolates. Now, lastly, Sulbactam, Dolobactam is the latest addition in the IDSA. This is now the preferred drug for carbapenem-resistant Acinetobacter, even pulling down the ampicillin sulbactam. But the only drawback is that the Dolobactam doesn't have an action against the non-New Delhi metolobeta-lactamase. But otherwise, the Dolobactam is sort of like blanket cover, which acts against a lot of the oxas, like OXA23, which is actually prevalent in our isolates. Now, coming to the novel tetracyclines. So as you know about all tetracyclines, they are independent of carbapenemase action, and they reach high concentration in tissues. So these are actually preferred in intra-abdominal infections and skin and soft tissue infections. So similar to tigecycline, we have eravacycline, which is also again recommended by IDSA for SSTIs and intra-abdominal infections. But just like tigecycline, it does not have an MIC breakpoint recommended by the CLSI, and its PKPD profile differs a little bit from the tigecycline. Now, there are really few studies on eravacycline, and you can see just 3 RCTs, 3 to 5 RCTs on this, and most of them have compared eravacycline against a carbapenem in intra-abdominal infections, and obviously that has shown a better result. Now, next is novel aminoglycosides. So we have plasmomycin, which is the novel one, which is actually a semi-synthetic aminoglycoside that is which has resistance to the aminoglycoside modifying enzymes, and it's actually active against a lot of carbapenem-resistant Enterobacteriaceae and MDR-Acinetto. It has been FDA approved for complicated UTI and pyelonephritis. It has actually a favorable safety profile with only 3.7% decrease in renal function, but it is not recommended by IDSA because of the really few clinical studies and its inefficacy in a lot of and its resistance in CR Pseudomonas. Now, actually, where all the beta-lactams come into play is actually in the critical care. Now, there's a real big issue in the critically ill. So you can see a lot of the MDR organisms being isolated in ICU settings. This has been proven by a lot of trials, including the trial that is undertaken by many countries. Now, even an retrospective data from India, which is actually observational study, showed a higher likelihood of mortality for XDR infections. And here, the most infections were in the lungs as well as the bloodstream. So you can see that in the data that is being provided in the study. So in the ICUs, you can see a lot of mortality happening there. And also, most of these are lower respiratory tract. So why am I concentrating on this? Because the PKPD in critically ill is different, and especially for polymyxins, the PKPD is difficult, and especially when it comes to HAP or VAP, the polymyxins are not recommended. It doesn't reach a good concentration in the epithelial lining fluid of the lungs. So what about the site of infection and resistance development? Now, the sites of infection basically, again, pneumonia and UTI, your polymyxins and tetracyclines are bad, except for colistin and uncomplicated cystitis for the UTI. And also, we know that beta-lactams are much better for bacteremia. It has good penetration in the lung. It is even good penetration in your kidneys and the lower urinary tract. Now, coming to systemic toxicity. So this is where polymyxins are really going to take a blow. So colistin, obviously, you know, it has a lot of nephrotoxicity associated with going above more than 10%. So this is a retrospective cohort study. We have a number of studies like this that shows its nephrotoxicity. And also, mind you, there is also a 5 to 7% chance of myopathies and neuropathies associated with polymyxin use, including polymyxin B, where you might contradict that there is lower nephrotoxicity. Now, this is where actually Dr. Subhasri can win a little bit of the debate, because resistance to BLBLIs are high, but it's not nil in colistin. So you know about the MCR1 gene, which was initially identified in China, and that was found in E. coli isolates. Now we also have in Klebsiella and Acinetobacter various other resistance mechanisms, which include the MGR-B gene inactivation, which is it is actually found in European countries like Greece and Italy, especially in Klebsiella isolates. Now, also, the European network also has detected around 29% of carbapenem-resistant Klebsiella were also colistin resistance, and this is increasing. And now, we are totally blind to animal husbandry and agriculture, where the use of antibiotics is still high, and there you can again see a lot of MCR1 gene coming up. This is not just reported in China, it's also reported in several European countries. Now, again, when you're talking about polymyxins, it's
Dr.
always
Sneha,
about
you may
combination
have another
therapy.
minute
Okay?
more. You may have
Sure.
another minute
Okay.
more.
Yeah, sure. So resistance development, especially in case of crab. Now, in Indian isolates, you can see this, that there is a sulbactam resistance because of a higher production of OXA23, which is present in 76% of our isolates as per the ICMR data. Now, overcoming that is the sulbactam durlobactam. So actually, the durlobactam has a blanket action, and it on PBPs. Now, phosphomycin, again, there are a lot of data against this. I'll skip that. And also monotherapy with tigecycline has a poor clinical outcome. So again, that is not the traditional. Now, I just want to throw some light on the actual non-traditional aspects. So you have phages, you have antimicrobial peptides and nanotechnology coming up. Phages, you have a lot of case studies that are coming up for difficult to treat situations where long-term is required. And yeah, this is being again published by the WHO. Now, this is my final slide, my thank you slide, where I would like to focus that the IDSA 2024 guidance, you will see that basically it supports the BL-BLI combination for various number of factors, especially with the PKPD, as even if the resistance pattern is higher. And you know that, again, WHO is searching for more important antibiotic combinations for MDR pathogens. Thank you.
Thank you, Dr. Sneha. Now we move over to rebuttal now, and Dr. Subhasri, over to you.
Yes, ma'am. Yes. I hope my screen is visible.
Yes, it's visible.
So my colleague very nicely highlighted all the guidelines and treatment options available for the Western countries following the IDSA guidelines and most of the Western data. So now I'd like to highlight the few of the backlogs or the few of the issues associated with these newer BLBLIs, keeping the context of the Western countries. So with this fancy molecule of Zabisepta, actually, so it fails to act against the metallo-beta-lactamases. So it is only an effective antibiotic or molecule where KPC and OXA48 is the predominant strain. So for most of the LMIC countries, it's not one of the good options. Additionally, the mutation of the KPC enzymes has made this molecule ineffective for even the KPC producing GNB infections. There is also a novel resistance mechanism which has been reported in E. coli isolates, especially. So that was PBP3, especially in the NDM harboring isolates, which makes the combination of Aztreonam avibactam or the ceftazidime avibactam combination ineffective. And also for giving all these molecules, so we have to detect whether the type of the CRE is KPC or OXA or MBL. So for which there is a lack of molecular testing, especially in the developing countries and with the resource limited settings. And then additionally, the synergy testing of ceftazidime and avibactam is essential before giving this molecule, which is not a routine practice in most of the setups, except some few tertiary care centers. Now coming to the molecule of ceftolozane tazobactam, which my colleague highlighted very nicely for the usage in Pseudomonas aeruginosa, but it lacks the activity against ESBL, so the co-producers may have an issue. So that's why for Pseudomonas aeruginosa, colistin or polymyxin B is still the better option. And in the absence of like the ceftazidime, so this is a very fancy molecule which even has an activity against the metallo-beta-lactamases, but it lacks the CLSI breakpoints for Acinetobacter baumannii. So still polymyxins continue to be the better options for the crab infections. This molecule of plasmomycin, so IDS does not recommend it, but it has a very good action against the MBL isolates, but there is co-production of aminoglycoside modifying enzymes with this, contributing its high emergence of resistance. And most important thing for LMICs, the countries like India, is cost and availability. Then, so coming to some Indian data from the Atlas surveillance data. So it's a data of 2018 and 19. So OXA48 was identified in 52% of Klebsiella pneumoniae isolates. However, the co-production was there in 27%. And NDM was the predominant, that is in 68% of the E. coli isolates. So making the ceftazidime avibactam a poor combination in our setup. However, so they summarize the susceptibility data, and the molecules like colistin and TG cycline showed 86 and 97% susceptibility in Klebsiella pneumoniae, and for E. coli, it was as high as 100%. So this was a very nice article which was recently published in Lancet Southeast Asia region, the loss of exclusivity of ceftazidime avibactam in the low and the middle income countries. So this was published by Balaji sir. So this highlighted the scenario of usage of ceftazidime avibactam as a last resort antibiotic in Indian scenario. However, it has been now started being used as an empiric treatment in Indian setup. So now there are some 10 pharmacy companies which have started producing this molecule, so which will reduce its cost and making its rampant usage and evolution of resistance. Additional, one more thing is ceftazidime avibactam and Aztreonam should be given as extended infusion, like for its proper efficacy because of its bioavailability. So this was a very nice article, so which was published recently, which showed that the ceftazidime has to be infused over 3 hours. However, the temperature should be 25 degrees Celsius. But in Indian scenarios, how much it is possible for the like peripheral settings to maintain this temperature of 25 degrees Celsius, that is debatable. So that's why the polymyxin B does not need such a longer duration of infusion. So over 1 hour that can be infused. So I would still go for this molecule over the fancy molecule of ceftazidime avibactam. And then coming to the other molecules like lung penetration, so which was highlighted by my colleague, Dr. Sneha. So I will say that so polymyxin B, so every molecule has certain PK/PD parameters. So Zabisepta, even though it is like very good lung penetration, you cannot use it empirically, especially in Indian scenarios, because Acinetobacter baumannii is the predominant isolate, like isolated from the VAC patient. So and it is intrinsically resistant to the molecule. So in that case also, you have to look for the local antibiogram, and then like based on that, you have to decide whether you should go for Zabisepta or polymyxin B based combination. And additionally, for CNS infections, polymyxin B has a better penetration over Zabisepta.
Excellent. I think that was a very good rebuttal. Now let's see what Dr. Sneha has to say.
Not able to share.
Ma'am, can you share now?
Yeah. Okay.
Your screen is visible, doctor.
Okay. So yeah. So yeah, I get the point from Dr. Subhasri that polymyxins, yeah, as empiric therapy, yeah, maybe for crab, but that's not what most of our isolates are seeing. And yeah, so I have a few studies that is gonna tell you why I still prefer Zavicefta against polymyxins. And yeah, so this is one study which was actually published this year, which was done in Chennai in South India. And this was a retrospective cohort study, which was done in 2 years in critically ill and carbapenem-resistant Klebsiella. And its outcome was all-cause mortality at 30 days. 165 patients were enrolled. 65 were in the ceftazidime-avibactam arm, as 41 in the colistin. And you can see that a lot of these, the higher mortality was in the polymyxin groups. And mind you here, they have used both polymyxin B and colistin, and still ceftazidime-avibactam showed a better clinical approach. Now, again, next study, which again showed the comparative efficacy against polymyxins, again from South India. So this is a Kaplan-Meier curve that actually showed the green one is the colistin and polymyxin arm, and the ceftazidime-avibactam is the blue, which was also used along with now, from day 14, they showed that the survival rates as well as the clinical outcome response of the ceftazidime-avibactam arm was much higher than the colistin arm. So this was again done in 89 patients, and the primary outcome was showing a better clinical response in these isolates. Now, again, I could take you through a lot of meta-analysis and systematic reviews that actually show you that these beta-lactams are much safer and equally efficacious or even better than colistins and polymyxins. So you can see this meta-analysis which looked into a few of the RCTs and compared both of these arms, and the result, as you can see, the underlined, the result is robust when a colistin-based arm regimen serves as the control group, and it's got a good p-value. And yeah, so in summary, yeah, I can agree as an empiric therapy polymyxins, because we do have crab and Indian E. coli which can be resistant to avibactam, but always as a targeted therapy, it is much better to go down to a beta-lactam inhibitor combinations, and always go for a de-escalation based on this, and especially in cases of pneumonia and also in bloodstream infections based on the toxicity to polymyxins. Thank you.
Thank you, Dr. Sneha. So do we have a poll at the end of the session now? So how many would actually vote for empiric polymyxin and how many for empiric newer drugs? Okay, so this is the... So do we have votes?
Yes, ma'am, let's start it.
Okay, I'm not going to waste too much time. I think both of you were really excellent. But I mean, this is to the audience. Please look at know your enemy. So think global, act local. So look at your enemy. We have a lot of NDMs, OXA48s. We do not have so much of KPCs. Yes, amongst E. coli, we have PBP3s as well. And we have acinato as one of your nosocomial infection. So when you start an empiric antibiotic, ensure that that's covered. Try to hold back ceftazidime-avibactam aztreonam without a synergy testing. You're already losing out on the molecule. About 40% of the Klebs and E. coli's, many more E. coli's are getting resistant to it. So please make sure you have a synergy testing done. Look at your own epidemiology and make an empiric choice at that point in time. So I think still we do have a revival of a lot of older drugs which are becoming newer therapeutic agents. Thank you so much. Thanks, Dr. Akshata, and a great applause to both the speakers. I mean, it was exhausting.
Thank you, ma'am.
Thank you, ma'am. Thank you for making time from your very busy schedule and being part of the small initiative. So with that, we move to the next talk. I would like to invite Dr. Rebuttal, sir. Sir is additional professor and head of Department of Microbiology at AIIMS Jodhpur. I had the privilege of being trained under him. Sir, over to you, sir.
Thank you, Dr. Akshita. And first of all, I would like to congratulate Dr. Akshita for organizing this very interesting debates. And we have had three very interesting debates till now. And the next debate is on Biofire being a boon or bane for the diagnosis of infectious diseases in the syndromic manner using multiplex panels. So I think we'll first have the pre-debate poll.
Yes, sir. I'm just sharing.
Dr. Akshita, are you sharing for me or should I share my screen?
Just a second. First, we'll have the poll and then I will let you share.
Okay.
You only share your screen. If there's any issues, then I will share. Yes.
Yes.
Boon. So majority are of the opinion it's definitely a boon. Over to sir. Sir, 100% are in favor for Biofire is a boon. We need not have a debate. Vipur sir. Ma'am, we can start.
Okay. Can you see my presentation?
Yes, ma'am.
Okay. Yeah. So, I'm good evening all. Thanks, Dr. Akshata, for this opportunity. So I'm Dr. Geetu Jo. I would be speaking for Biofire. I definitely think Biofire is a boon, and my short presentation will be to support that. And my motto, I think I only have to convince now Dr. John over here, because everybody else I seem is already convinced of the fact. Anyways, so Biofire, they are multiplex PCRs. They are also known as syndromic panels that combine numerous pathogens and resistance genes into a single test. So this test, as my ID physician calls it, it's a leapfrogging innovation where, the traditional methods, which are cumbersome, require skilled labor, have a longer turnaround time, detect limited range of pathogens, maybe the fastidious organisms cannot be very well detected. All this is being covered by the multiplex PCRs. So to put it in simpler terms, why should I have an additional syndromic testing along with the conventional ID-AST? If your sample is being taken, by the time your lab technician collects all her smears for the gram staining batch, the rapid ID and AMR report, if my syndromic testing is being coupled in, is already ready way before my gram stain results, by which the clinical team can immediately switch from empiric to targeted antimicrobial therapy, which otherwise happens, after day 3. It needs to grow. After it grows, you need to put up an ID-AST conventionally. Once it's ready, then only you can switch to your targeted therapy, or at least you can confirm that your empiric therapy is actually your targeted therapy. So I would like to convince you all on this by a few cases. My case one is of a 31-year-old male patient post-renal transplant. It happened in 2021. He was on this particular prophylaxis. At that point of time, when he presented to us, he was on Visolone TAC MMF.
March 2024, he presented to us with multiple episodes of loose stools. He was hypotensive. He had no fever. He was admitted in the ICU. The stool culture was done, which was negative. Now what? Now we took a rectal swab. We didn't even wait for him to pass his motion. A rectal swab was transported in a carry-Blair medium immediately to the lab. Within 1 hour, 15 minutes, the result was ready and it was salmonella. So salmonella, is it difficult to culture in the lab? Maybe yes, because it requires enrichment media even after doing all that. So in my lab, I put it in selenite F broth. After 4 hours, I subculture it onto XLD. Say, all the H2S producers of salmonella picked up by the black colonies. The rest of them are picked up as the red colonies. So all that is done. So these are my stats. From 2022 till date, I had total of 198 GI biofires, out of which 15 showed salmonella on the biofire, on cross-culturing, out of which only 2 were culture positive. Similar result was portrayed in the poster in ECMID in 2018, which said high rates of isolation of salmonella was seen, which was very remarkable in comparison to the culture. This same patient in April 2024. So previous happened in March. A month later, he presented with mild cough, throat pain, fever, chills, exertional breathlessness for 5 to 6 days, raised WBC count, CRP was elevated, he had bronchi. You can see his imaging. There were central and peripheral areas of ground glassing opacities. There were central lobular nodules. So what were our differential diagnoses? We, as in the ID team, the DDs were put up. Viral was on the top of the list, bacterial, then TB, then PCP, Aspergillus, mucor. So in a normal lab setup, apart from the viral diagnostic labs, how can you include or exclude viruses in your diagnostic facility? It is merely impossible without the help of these beautiful tests, which are validated. So this is the Biofire Respiratory 2.1 plus. Earlier it was 2.0 with the inclusion of SARS-CoV-2. So this test, you name it and it has all the viruses. It has adenovirus, it has all your endemic coronavirus with the different subtypes. It has SARS-CoV-2, metapneumovirus, influenza, para-influenza subtypes, RSV, your atypical bacteria, which you again cannot grow in your lab. So 23 targets in 45 minutes. And the test came out to be negative. Were we unhappy? No, absolutely no. With the excellent negative predictive value of the test, we took the decision of subjecting the patient to an invasive procedure like bronchoscopy because we knew that it wasn't a viral disease. The BAL expert was done on the bronchoscopic sample, calcofluor for the fungi, it was negative, galactomannan negative. The LRTI biofire on the bronchoscopic sample showed us a sole pathogen, Haemophilus influenza 10 raised to 6 bin copies. So what are these bin copies? They are nucleic acid copies per ml, something equivalent to our semi-quantitative culture where you call it as colony forming units per ml, but this is way more sensitive and way more rapid. So the LRTI grew Haemophilus influenzae, patient was on piptazo. Now we knew what was the targeted therapy to be given. We changed it to oral augmentin and he improved. So the conclusions from the 3 biofire tests which I ran for a single patient, even a negative URTI was of utmost importance. It ruled out the virus, atypical, search for the bacteria got intensified by the team. Good negative predictive value of the test was remarkably helpful to us to go ahead with the other invasive procedures. H. influenzae being fastidious, patient was already on piptazo. There was no chance I could grow it, and the same thing happened. We couldn't grow it on culture. Now coming up to my second case, a 61-year-old female, renal transplant in 2022. She was on this particular prophylaxis, loose stool and abdominal pain for 15 days. Again, same thing, a GI biofire was run, norovirus. So what does this patient need now? Now, it is an infection control precautions that have to be taken. We all know the shedding of norovirus can happen for more than 3 months, much longer if the patient is immunocompromised. Immediately, we tell all our nursing team and all the medical staff attending to the patient that the alcohol-based sanitizers can only be used as an adjunct in between proper hand washings. They shouldn't be considered a substitute for soap and water when you're dealing with a norovirus. Sodium hypochlorite being a key approach to interrupt the norovirus from the contaminated environmental surfaces. So the GI panel gives us quicker results. It reduces the time to antimicrobial therapy, a more targeted therapy. This patient did not require any upgradation of antibiotics. In fact, the antibiotics need to be stopped. And all procedures like endoscopies and abdominal imaging was avoided. Now, case 3 and case 4 in the form of few case units, where a 80-year-old male, post-operative spinal abscess, MRSA bacteremia, lots of secretions, imaging revealed a left collapse consolidation. On bronchoscopy, a mucus plug was seen, which was removed, and this particular lavage sample was subjected to biofire. You can see the big list: Staph aureus, Klebsiella, E. coli, Serratia, along with the AMR genes. Now, what should be done in this case? Should we treat or no? The ID team chose to treat this valuable information for the impending pneumonia, which could be caused due to the mucus plug. Mucus plugs occluding the bronchi can increase the risk of the pneumonia. Could we risk in this elderly patient who was post-operative? No. So with that information, we chose to treat. Now, you may have a test. You should know how to use the test and how to, finalize your treatment based on the results. Now, this was a 43-year-old male, IC bleed. He had a fever. X-ray was normal. The primary consultant ran a biofire on his sputum, which showed E. coli and Pseudomonas 10⁵ bin copies, NDM, Vim. Should we treat or no? Fever is common in the intracranial hemorrhage patients. It is not associated with a clear infectious etiology, we all know. So the ID team didn't treat this patient and asked them to wait for the fever to settle, and the patient recovered normally without any treatment. So we should know that these assays improve detection of potential pathogens, but incorrect interpretation of the results may lead to inappropriate therapy. So we should blame ourselves and not the diagnostic tests. And the quality of the sample is also vital. So scoring system should be applied. Obviously, you should screen the sample before running the test, but that doesn't apply for the atypical bacteria and viruses again. Now coming to my last case, a 52-year-old male. He underwent a surgery for a CP angle tumor in 2022, December 19 specifically. An Ommaya reservoir was placed. On 27th of December, say almost a week later, he became febrile. He got drowsy, headache, vomiting. This was a CSF routine. Nucleated cells of 6,800, almost 97% were neutrophils. Sugars were low, proteins were raised. It was culture negative. In fact, this patient was referred to us from an outside hospital. CSF lactate was done, which again showed us that this was a meningitic picture. So my ID at my hospital, to whom this patient was referred to, my ID physician, he asked for a CSF GI panel. So why a GI panel? This was the time, where I newly started the GI panel in my hospital. So the answer he gave to me was, this is your ME panel. Your ME panel has these bacteria: E. coli, Haemophilus, Listeria, Neisseria, strep viruses, and Cryptococcus. Whereas your JI panel has your anaerobic organisms, has Proteus, Pseudomonas, Salmonella, Serratia, Staph, several resistance markers. This test also has incorporated several resistance markers. So his point of view was, these pathogens which are covered in the ME panel are dealing with community acquired meningitis, whereas in our patient, this is something to do with a hospital acquired meningitis. So we ran a GI panel in a culture negative, which has happened outside. The culture had happened outside, and it showed Pseudomonas without any resistance genes. A decision to give an intrathecal colistin was taken, and the Ommaya reservoir, you can see the shunt tip was removed, which also grew Pseudomonas. So to conclude, I would say syndromic testing versus traditional testing. Syndromic PCR, your biofires, they are rapid, they are more sensitive. Determining the cause of a viral infection, though there is no specific treatment, you can avoid unnecessary antibiotics, you can reduce the stay of the patient, and your patient is extremely satisfied knowing what he has. It also detects parasites and fungi for relevant syndromes, which helps the healthcare providers to avoid any guesswork and other kinds of testing. In addition, identifying the resistance genes can also help you, reduce the use of unnecessary antibiotics. You can decide whether you want to not change your empiric therapy, you want to escalate, or you want to de-escalate. Thank you. So these are my acknowledgements. Dr. Soman, who needs no intro, our current ID fellow, Dr. Tejas Bende. So I would like to stop with a disclaimer. Syndromic testing has really changed how we diagnose the infections, leading to an improved patient care, antimicrobial stewardship program, and a clinical workflow. Thank you.
Thank you, Dr. Geetu. Now, can we have Dr. Nikhil to present his...
Good evening, all. Thank you, Akshita ma'am. Thank you, Vibhor sir. Before I start, with the end of Geetu ma'am's presentation, I already feel like a villain. I don't know how many people I'm going to convince. I'll try my level best. Yeah.
Can you share?
Is it visible, ma'am?
Yes. Put it on slideshow.
I'm not able to see the full screen, ma'am.
Can you put it on slideshow?
Yes. Now I'm able to see it.
Yes.
So, good evening all. Once again, I'm Dr. Nikhil John Research. I finished my MD Microbiology from AIIMS Jodhpur. I'm more than happy to have worked under a lot of people attending this debate series, and I owe all my microbiological knowledge to them here. Thank you. So, Biofire. So we all know from what ma'am beautifully explained that yes, Biofire is a tool in a clinical microbiologist and ID physician's armamentarium to diagnose and treat infectious diseases. Yes, it is true. But are there any gaps in its armamentarium? Are there any gaps in its armor? Biofire may stand as a huge Goliath, as a huge giant in front of us. But we have to be cautious when we use this test. We have to be careful before we implement the results of these tests onto the patient. So is it the one-stop solution for all your clinical microbiological needs, or should we revisit and look at other options also? So as David picked up a few pebbles to hit Goliath, so I'll humbly pick up a few pebbles to try to see if there are any gaps in the armor of the giant Biofire. So as I mentioned here, there are a few coverage gaps with respect to some panels in the Biofire. There are a few technical limitations. There are chances and risks of false positive and false negative reporting, chances of over-reporting, and difficulties with clinical interpretation. There are also some technical limitations and statistical limitations, and not to forget the cost and accessibility. We'll start with a small clinical case. We have a 52-year-old farmer from Tamil Nadu who's had a history of fever for 7 weeks, intermittent with no significant response to antibiotics. He's a known type 2 diabetic, on and off medication. He had a history of minor trauma while working in his paddy fields 3 months back. With mild leukocytosis and elevated transaminases. He was diagnosed. They tried to diagnose him. The DD for tropical fever panel of what is all mentioned here turned out to be negative and non-reactive. Now here there are two doctors. One clinician who directly ordered a Biofire wanting immediate results, and one clinician who ordered a Biofire and also did other laboratory tests which we do traditionally. The clinician who ordered only the Biofire test came out to be negative, and he didn't know what else to do. Whereas the person who ordered the Biofire along with the conventional and traditional microbiological approach, on the beeped blood culture bottle, gram stain was performed, and he was able to see gram-negative bacilli with typical safety pin appearance, the bipolar staining. Now I know where we are all going with this. On the McConkey agar, as the colonies matured, they started becoming dry and wrinkled. They were oxidase positive, and when the 3-disc test was performed, they were resistant to colistin and gentamicin, were susceptible to amoxiclav. So any takers for which organism this is with the given history and the diagnostic clues? So this patient was diagnosed to have Burkholderia pseudomyelitis, case of melioidosis. So in this case, if you blindly order a Biofire test for a person pyrexia of unknown origin for any bacteria for that matter, things may not turn the way you want to. So I insist on ordering tests judiciously. So what tests or what does this test for? The BCID2 panel, as it was revised recently, it has a list of organisms that they cater to. A lot of non-fermenters are not included in this list. As we just saw, Burkholderia, Pseudomonas. So there's always a holistic approach which is required. There's always a method to the madness. So the list goes on. This is a study in which they recognize the pathogens that are not detected on the BCID panel. You have a lot of aerobic bacteria, gram-positive bacilli, gram-positive cocci, other organisms. You even have anaerobic organisms. You even have fungal agents on this list. So the important takeaway here is diagnostic stewardship is key. As ma'am said, the technology is good, but it depends on whose hands it is and whose eyes see the technology and the results that it gives. So another thing, a lot of people say that Biofire has very good turnaround time. Yes, I do agree. But with so much technology and so much money being spent, we still can't test your Biofire testing on a direct blood culture sample. It has to be incubated, and the flagged bottle only goes into your Biofire. So blood samples cannot directly be tested, and this I see as another problem to this test. So coming to our next case, here we have a 68-year-old female with right knee arthroplasty 2 years back, pain and swelling, warmth over the knee for the last 3 weeks. On physical examination, there's erythema, effusion, tenderness over the prosthetic joint. Synovial fluid, as you see, is turbid, high neutrophil count, and the gram stain showed gram-positive cocci in clusters. Yet, when a Biofire test was performed, the organism wasn't detected. So, as we see in prosthetic joint infection and other periprosthetic infections, organisms which you think are of low virulence, such as coagulase negative staphylococci, Cutibacterium acnes, the earlier named Propionibacterium. So all these low virulent microorganisms turn to be potential pathogens and significant pathogens in a given situation. So this JI panel, the usefulness of this panel is limited because it does not detect coagulase negative staphylococci and Cutibacterium acnes, and there are also chances of cross reactivity. If you go through the brochure of the JI panel, there are a lot of cross reactivity in the species level when it comes to a lot of gram negative bacteria in the JI panel. So this is a meme that I'd like to share. If you've all followed the Olympics, like Biofire film array as the multiplex nested PCR, all the equipments trying to detect cons on a GI panel where a simple gram stain culture and coagulase gets you the medal. Yeah. So going to our other problems, or as you may call it cherry picking, is Biofire alone were included in this review, and 18 studies were pooled for meta-analysis to test the diagnostic accuracy in the meningitis encephalitis panel. So if you see here, there are a lot of false positives with respect to Streptococcus pneumoniae. You're able to see 17.5%, Streptococcus agalactiae 15.4%, and E. coli 11.1% notably. And with respect to the false negatives, you have enterovirus, you have HSV1 and 2, and Cryptococcus neoformans bargati. False negative Cryptococcus neoformans bargati were mostly patients with positive antigen titers on treatment or cleared disease. So here we have another set of 45 patients where false negative Biofire film array meningitis encephalitis multiplex PCR assay for cryptococcal meningitis was done in UCSF. So here you are able to see the discordant results. There were 12 discordant results, and a lot of these patients had a significant high CRAG titer. Some of them had positive Indiaing, positive culture. A point to note is the patients were already on antifungal therapy, which is low fungal burden. The technology had problems detecting this cryptococcal meningitis. So coming to another hot topic with respect to SARS-CoV. So here this is another letter to the editor where a study was done comparing a Biofire for SARS-CoV-2 with the RP 2.1 panel and the Cobas Liat and the Cobas 6800 systems from Roche. So here the clinicians had ordered for the Roche test in view of the cyclic threshold. So among the 56 specimens positive by the Biofire panel, 47 were rechecked. So here 20 out of the 47 became negative by either system. Both the Cobas systems showed negativity. So this is again to consider like your COVID testing with respect to Biofire. This is another study in Morocco where the Biofire COVID panel was tested with another MASCIR 2.0 assay. Yes, ma'am. 2.0 assay, and there are a lot of discordant results between both the tests. So coming to the semi-quantitative assay, which ma'am was also talking about, there is good concordance when 10 to the power 7 copies are present, whereas when it is 10 to the power 4 to 6, the concordance is very low, and it is very difficult to differentiate colonization from active infection. So as you see, these are the pathogens. On the top, you're able to see the semi-quantitative approach, and bottom, you're able to see the qualitative approach. So the problem with Biofire, ma'am was pointing towards its good negative predictive value. Quick to this technology is the low positive predictive value, indicating that we can detect pathogens effectively. It can detect pathogens, indicating while it can detect pathogens effectively, not all detected pathogens correlate with pneumonia diagnosis. The odds ratio for pneumonia was significantly higher for culture positive results compared to the pneumonia panel positive results. And culture always remains gold standard. This was done in a study comprising 840 people. So it's like picking up a chit. You don't know which one's going to come today. It can be 1, 2, 3, or 4. And after that comes, you don't know which one to choose. You're again back to square one. So with respect to GI panel, ma'am told that yes, it has parasitic coverage also, but the parasitic coverage, for example, with respect to Cyclospora cayetanensis, the unit is in genome equivalence, and this does not, it is unclear as how this relates to the number of oocysts in the clinical sample. So it's difficult to assess in follow-up the patients on treatment and to calculate parasitic index. So now another thing, as ma'am discussed with respect to the Salmonella case, the rectal swabs which the Biofire GI panel has poor diagnostic yield compared to the stool specimens in caribulary medium. It's not FDA cleared. There's lack of antimicrobial resistant genes in the GI panel, and the GI panel comes with a pinch that it's expensive than the other panels also. So coming to a few technical limitations, where the internal control used here in our Biofire is Schizosaccharomyces pombe, a bit of a tongue twister. This is prone to a lot of non-homologous recombinations. So here a question arises as to whether this is again a robust control or do we have to look for alternatives. Coming to the double-stranded DNA binding dye, which is LC green, which is used in this technology, when it comes to long PCR products, there are studies saying that it is less effective and can lead to missed detections of small sequence variations, especially the primers are long, and there are chances of overlapping melting curves also, again when the primers are long. So again, you may ask, what is this Triton X? When you do the test, you have a red color vial, which is a sample injection vial. So this Triton X and guanidinium chloride, there are two chemicals in it. The Triton X in it is used to release intracellular materials, including nucleic acid. So this is known to have endocrine disrupting properties, and the REACH organization in Europe gave it a sunset date of 2019, but it is still in use. So there are technologies coming up with alternatives to Triton X, such as Tergitrol 15S9, and I feel this will be encouraged in the future. So again, coming to the end, will Biofire burn a hole in my pocket? That is, individual takers have individual opinions. So I'd like to finish my talk by saying this beautiful quote by the first woman editor of JAMA. Remember ordering a diagnostic test is like picking your nose in public. You must first consider what you will do when you find something. in our case, this quote applies literally. Thank you. I rest my case.
Thank you, Nikhil. Vibhor sir, are you there?
Yes, I had some network issues at my end, and I joined in between when Dr. Geetu was presenting. So I think this is time to take some counterpoints from Dr. Geetu if she wants to address and counter Dr. Nikhil.
Very few, sir, but yes, I want to. So I'll
Please,
just
please go
quickly
ahead.
share. Dr. Nikhil, can you discontinue sharing?
Yes, yes.
Yeah. Yeah, so I won't take much time. So I prepared my presentation for the rebuttal while Dr. Nikhil was presenting. I thought that was the best to do. So let me start by saying he called the Biofire as a Goliath. I think all of us should become David and we should know how to tame the Goliath. That is how we'll become the winners. And he called it as a one-stop. I mean, he said that it couldn't be a one-stop solution, but yes, you should consider it as a big strength into your diagnostic community where you can provide, rapid diagnostics and you can support your culture results as well. And now quickly, so the traditional diagnostic methods, I've already mentioned all these points. I'll just try comparing a few methods. Say the bacterial culture. Again, poor sensitivity. How will you grow the fastidious organisms who have already received prior antimicrobials? So your point here, Dr. Nikhil, where you said, the lower bin copy values, yeah, they have to be taken with a pinch of salt. You have to correlate them. But in such patients where they have already received prior antimicrobials, also such a scenario can be encountered. Then there will be a potential contamination with your normal oropharyngeal flora, even in your bacterial cultures. And your bacterial culture, as I already mentioned, longer TAT, it is labor intensive. The interpretation in culture also can be subjective. It requires, again, facilities, reagents. Now coming to your AST methods, different methods. Some methods only don't have broth microdilution as provided by a Vitek. They only have the disc diffusion. Again, you'll have to be very careful. Then it's labor intensive. It all depends on your personnel, how they perform. Longer TAT, limited use again in your fastidious and atypical organisms. Now coming to your urinary antigen test, they are very good innovations, rapid, bedside, but they have the problem of poor sensitivity. Then coming to your other NATs, nucleic acid amplification tests, as they are commonly known for beat viruses, atypical bacteria, or be for any other organism, you first of all need a PCR facility for all this. The Biofire has evaded the necessity of a PCR lab in the first place. The entire machine is a whole sort of a PCR lab. They have ready-made reagents. You just need to process the sample. Learning the technique, you do not even need to train your technicians on the molecular techniques. It's that simple. A very basic, simple training, and they are all set to run the Biofire for you. So you have everything on that. You do not have to run several single-plex assays. Now coming to the case shared by Nikhil, where Dr. Nikhil, where the pseudomalley grew. So we also had a similar case, a retroviral disease patient who grew Pasteurella multocida, which I minus from my presentation because due to the lack of time. So you have to keep in mind of the off-panel BCID organisms also. For example, aggregati bacteria, Aeromonas, Pasteurella, Vibrio vulnificus, and you should know their source. Are they community acquired? Could they be waterborne? The pseudomalley is already there in the list. So at least you will get an idea before the culture grows. I agree, you have to run it on a flag positive bottle, but you needn't even wait for the culture to come. You needn't even see if they are non-lactose fermenting colonies. You do not have to do your oxidase test. Once your bottle flags positive, you already know that you're dealing with something different. Now, how to interpret your bin values together with your culture reports. I understand the bin values, the rounding up of the values, giving you, copies per ml is difficult. But like you correlate for your colony forming units per ml, there is also an understanding how to correlate it for your bin copies. Like how you call in ET aspirate, you know, it should be more than 10 raised to 5. In BAL, it should be more than 10 raised to 4. Similarly, a roundabout value can be made for your bin copies. So the quantitative agreement for bacterial targets, they say that a bin value above with a quantitative culture is as good. If it is more than 10 raised to 5, then you can treat it as highly sensitive and specific. It shows a very good concordance with the quantitative cultures. Yeah. So I end my rebuttal over here. So basically what I want to say is, as my ID physician always keeps calling it, I also truly believe it is a leapfrogging innovation. We have to, rather than looking for all the negatives and all the very few lacunae which are left over, I'm sure, which will be covered very soon in the following maybe years, we have to in fact embrace whatever we have been gifted with now and try to make the best use of it. Thank you.
Thank you, Dr. Geetu. Now, if Dr. Nikhil wants to respond again, so a quick response from Nikhil if he wants to.
Yes, sir. So I have a few points in my rebuttal.
Nikhil, you are
especially
there?
with respect to. Sir, am I audible? Sir,
yes.
Am I audible? Yes. Yeah.
Yes, Nikhil. Yes, you are.
So I have a few points for my rebuttal with respect to a few cases which ma'am had shared. So with respect to the norovirus case which ma'am shared, so there's a study from Canada by Nancy Matic in Vancouver where they have reported 20 to 25% false positive cases in especially norovirus because there's an atypical melting curve which they've got with the noro 1 target, and this is statistically significant odds ratio. So studies like these, when they come up, so we again, as ma'am said, we'll have to take it with a pinch of salt. We won't know whether this is a real norovirus case or are we looking at false positives. So this is one thing that I wanted to address. And again, the rectal swab case which ma'am discussed, so FDA hasn't cleared the GI panel for the use of rectal swabs. They only cleared it for the use of stool specimens carried in carry-Blair medium. So the sensitivity and specificity of the test decreases remarkably when rectal swabs are used. And again, with respect to the Haemophilus influenzae case, which ma'am said, so this 10 to the power 4 to 10 to the power 6 is a dicey area when it comes to the semi-quantitative bin copies. So again, when you have a test which gives so many options and you end up again in square one. So another thing I'd like to tell for all the users of Biofire, if your technician is having a cold or a cough, kindly refrain him from using the processing of a Biofire. It may again end up with a contaminated but technicians, I urge everyone to be careful.
Thank you, Nikhil. And I think we'll have first both the speakers. They put up wonderful points, both for and against the use of Biofire. And I think first, before I give my concluding remarks, I think we can have the poll from the audience. What is the thought process of the audience? Whether they think that Biofire is a boon or a bane.
Sir, you can start speaking, sir. They will respond.
Okay. So the audience, I don't know how many numbers have really participated in this, but here what I can see is Okay, the result is now changing. Okay. So whatever the results of the poll are, I believe that it is an addendum to the diagnostic armamentarium we are having. But yes, there are various limitations of this test. Uh, the cost is a factor. Then the limited number of pathogens which can be detected, that is another limitation. Then the quality of specimens which are being tested, how well the specimen or how in aseptic manner the specimen was collected, that will be a limitation. Then the number of organisms which are present in the specimen, that thing also will need to bear in mind. And plus, most important, it is going to be the clinical correlation and the clinical scoring systems which we are going to use along with this. So both when the mind and the machine, they are simultaneously used, our clinical medical knowledge uh, use of along with the use of our medical knowledge, and then the test results interpretation, that is going to make all the difference, and that is going to change the that is going to guide us for the appropriate management of the cases. So with that, those are my concluding remarks, and over to you, Akshita.
Thank you, sir. Thank you for making time from your busy schedule and agreeing to be a part of such a small initiative. With that, we move to the next topic. I would like to invite Dr. Mihir R. Gangakedkar, who is a consultant pulmonologist at Fortis Hospital, Mulund, to take over. Over to you, sir. Dr. Mihir, sir.
No, am I audible?
Yes, sir. Yes, sir.
Yeah, sorry. Hi. Good evening, everyone. Thank you, Dr. Akshata, for having invited me. And our topic for today is latent tubercular infection and solid organ transplant. Latent tubercular infection in itself is something that divides societies right all the way in the middle. And for this, we have two worthy opponents. Speaking for the motion, we have Dr. Kriti, who is an assistant professor in pulmonary medicine at Tata, Kharghar. And speaking against the motion, we also have Dr. Shivang Sharma, who is an assistant professor in infectious diseases. So at Manipal. So I would call Dr. Kriti to start off with her discussion first.
Hello, can you hear me?
Yes.
Thanks a lot, Dr. Mihir, for the kind introduction. And thanks, Akshita, for organizing this wonderful series and inviting me over. For some reason, I think my video is not working, but I'll directly share my presentation. Are the slides visible?
No, Kriti. Can you reshare? Or
Yeah.
you want to share?
Yeah, just 1 second.
Yes, it is visible now.
Okay.
You can put it on slideshow.
Yeah. It's visible now?
Yes.
All right. Starting off the topic of debate now for this session is, should LTBI screening be done before solid organ transplant? Yay or nay? And I am speaking for the motion. Before we jump directly into the topic, I'd like to go through a few terms which will be encountered during my presentation. Tuberculosis, TB, active TB, TB disease would refer to the disease state due to Mycobacterium tuberculosis. LTBI or latent TB infection refers to a state of persistent immune response stimulation by Mycobacterium tuberculosis. Two main screening tests are available with no evidence of clinically manifest active TB. Two main screening methods are available for LTBI: TST, that is tuberculin skin test, and IGRA, that is interferon gamma release assay. A high TB incidence country refers to a country with a TB incidence of more than 100 per 100,000 population. Coming to the logistics of these two tests that are available, IGRAs are more expensive, technically more complex to perform. IGRA requires phlebotomy, which may be difficult for young children. It requires laboratory infrastructure, technical expertise, and expensive equipment. A single visit, however, is required to obtain a result, and it is unaffected by BCG, which is important. Coming to TST, it is less costly, can be performed in a field, but it requires a cold chain. It requires training in intradermal injection, reading, and interpretation. 2 healthcare visits are required for TST administration and interpretation. Strain of BCG, age of vaccination, and at reading may affect TST specificity. Points to note is neither the TST nor the IGRA test can distinguish latent TB from active disease. Both of these tests should be interpreted with caution in patients receiving high level of immunosuppressive drugs, as they may yield falsely negative or indeterminate results. And this is the population we are talking about today. The screening for LTBI should be done prior to administration of immunosuppressives, not after. IGRA tests are highly specific, and a positive test should be interpreted as evidence of Mycobacterium TB infection. Both these tests have low positive predictive value of 1 and 2%, but their negative predictive value is very high. How do we go about this in clinical practice? When we encounter a high-risk patient, high risk for TB, we have to ask regarding any symptoms of active TB. If there are no active symptoms, we have to administer TST or IGRA. If it turns positive, we have to rule out active TB. If there is no evidence of active TB, the patient is treated for LTBI. If it is negative, we can proceed with the organ transplantation. If there are any symptoms of tuberculosis, again, the patient has to be investigated for TB or any other disease. Let's now come to the question. Here on my screen, you can see the numbers. Patients post solid organ transplant, incidence of TB, this is the overall incidence, is 2.3%. In a TB endemic country like ours, the number is as high as 8.6%. Mortality post solid organ transplant is around 18 to 30%. The lowest reported is 9%, and in TB endemic country is 19%. Graft rejection rate is again high, 15% post solid organ transplant in overall, and in TB endemic countries as high as 33%. That is, active TB among solid organ transplant patients is 20 to 70 times that of general population. How can a patient post solid organ transplant develop TB? 3 modes are there for developing infection: either a de novo infection like any other patient, as TB is a communicable disease, or from the donor who he has received the transplanted organ from, or by reactivation of latent TB, which is the most common mode. Time of presentation: most of the active TB occur in the first post-transplant year, and the median time for presentation being 6 to 11 months. What is the issue in treating tuberculosis post-transplant? The major issue is the drug interactions with rifampicin. As you can see on the screen, rifampicin has major interactions with the most commonly used immunosuppressive drugs, prednisolone, cyclosporin, calcineurin inhibitors, mTOR inhibitors, and MMF, mycophenolate mofetil. All these drug levels are reduced by rifampicin, and rifampicin is the most important drug of our antitubercular regimen. Overlapping adverse effects, hepatotoxicity, renal toxicity, poor tolerance, compliance, interactions with other antibiotics, antifungal, antiviral drugs, and all these drugs are commonly used in post-transplant patients. These issues make it very difficult to treat active tuberculosis post-transplant, which makes treating latent TB more important. What do the guidelines and recommendations say? All recommendations, starting from the recommendation by the transplantation organ transplant guidelines, recommend LTBI testing as well as screening as well as treatment. The CDC and WHO also go on the same lines, recommending LTBI testing as screening as well as treatment, and they are strong recommendations. Coming to ERJ, other questions or along with recommending LTBI screening as well as treatment, questions on discordant results of IGRA versus and TST are addressed. What if you get a different results with TST and IGRA? It recommends that the positive result should be used in clinical decision making, and if the both TST and IGRA come negative, but still we see any calcified lesions on chest imaging, or patients with a strong history of positive TST earlier, or patients coming from TB endemic countries, these patients before solid organ transplant should receive TPT, TB preventive therapy. Let's come to few studies, and I am going organ-wise. This is a systematic review and meta-analysis of patients who are kidney transplant recipients. Around 13 studies were included in this meta-analysis. Risk of active TB infection for kidney renal transplant recipients was lower in the INH treatment group than those without prophylaxis. But, however, there was no significant significant difference between the two groups in mortality, acute rejection, and hepatotoxicity, because hepatotoxicity or renal toxicity we would think might be an issue in giving LTBI treatment. Coming to the meta-analysis of the patients post-liver transplant. 224 patients with a positive pre-transplant TST results, amongst which 61 received more than 6 months of isoniazid, 16 received less than 6 months of isoniazid, 5 received rifampicin, 143 did not receive any LTBI treatment. With 54 months of follow-up, none of the TST positive patients who received more than 6 months of isoniazid LTBI treatment developed active TB. However, 7 patients who did not receive LTBI treatment, that is around 5%, developed active TB. Third organ, post-lung transplantation. This is a study with 398 consecutive lung transplant patients included. Around 30 patients received the LTBI treatment and 62 patients were not treated by LTBI. None of the TPT treated patients developed TB after transplant, whereas amongst the 62 patients who did not receive LTBI treatment, 3, that is around 5%, developed TB. Concluding, TB infection rates are higher post-solid organ transplant. TB is associated with higher mortality, graft reduction post-solid organ transplant. LTBI screening is cost-effective. It is safe. Tailored TB preventive therapy in LTBI positive patients before solid organ transplant reduces risk of active infection without major adverse effects. Over to the moderator.
Thank you, Kriti, for your discussion, and apologies to Dr. Shivang Sharma, who is going to be speaking again. So he is a consultant in infectious diseases at Zydus Hospital, Ahmedabad. Opposition to LTBI screening and also the LTBI prophylaxis that one would want to think for solid organ transplants. Thank you. Dr. Shiva. Are you there, Dr. Shiva?
Hello, sir. Yes.
Yeah.
Am I audible?
Yeah, you are now.
Share the screen.
Yeah. Okay. So I think my screen is visible.
Yes.
It is.
Okay. Thank you, sir, for kind introduction. And I will be speaking against the routine LTBI screening in the SOT, and the topic is Indian setting. So we will be debating for the necessity of routine screening. So, as already my opponent has already introduced the LTBI versus the active tuberculosis, so we'll not discuss much. And the importance of screening in high risk populations. Definitely in high risk populations, there is a role of LTBI screening, especially those who have a prior history of tuberculosis, and those who have exposed to tuberculosis. These in this kind of high risk patients, definitely we can use. But the focus of this debate, the major question to us is, should a routine LTBI screening to be implemented for asymptomatic donors and recipients? So the question is this. So if we talk about the Indian settings or South Asian settings, so this is what I found. Last year, it has been published that it clearly says that most transplant centers in the South Asian region do not routinely conduct the LTBA screening, that is TST or IGRA, in asymptomatic patients with normal evaluations and no history of TB exposure. And there is also varied practice, while some centers are doing this, but it is not uniformly practiced due to contextual challenges related to the endemic environment which we have. There are also limits. There are also limits of the screening test. As we all know, the TST, that it can have a false negative due to cutaneous energy in the post or renal failure patients or liver failure patients because of decreased immunity, and the overall sensitivity and specificity for the predicting post transplant tuberculosis is very low if we talk about the TST. Now, if we talk about the IGRA also has limited research on the predictive validity of the IGRA, especially in kidney failure patients and transplant populations in the South Asian region. And the existing studies which my opponent has already been has been discussed, which is all are of a Western origin, and still, if they are there, but they are still inconclusive. So it is not proving that it will improve the mortality, rather it will increase the toxicity also. So by this, we should also think about the IGRA limitations also. And the global screening recommendations are primarily based on the low endemic settings, which already there are a lot of papers published for the low endemic settings, that is the Western countries. But what about our countries or our South Asian region, where we have a high prevalence of tuberculosis burden, and there are no studies or negligible studies available for the IGRA especially. Also, there are implications of routine screening also. So if we make a routine screening of LTBI, what we will do, we will put a significant financial burden, logistic burden on the healthcare systems, and especially in our resource limited settings, and we will divert the resources from more critical health issues like detecting the active tuberculosis, rather than to check for the asymptomatic carriers. Also, there will be a low impact of the guidelines. There will be a small proportion of the patients, transplant candidates may benefit for this patient for this routine screening, but eventually, if we see, it will not be much of useful if we put as a routine screening. There is also a risk of prophylaxis. If you have checked the IGRA and it came out to be positive, now you are putting a patient on a prophylaxis. Now, what do your prophylaxis really prevent in high endemic countries like our India? Especially, there is a high endemicity of the multi-drug resistance patients, where you expect the isoniazid resistance also. This paper, this is showing the we have highest number of burden of MDR tuberculosis patients also. And this article is showing that there is also monoresistance in the previous on a new cases, where we can find 11% of resistance to isoniazid. So what we are dealing with the isoniazid resistance patients also. So this can be, and if we see the renal failure patients and liver failure patients, they can have already a past history of tuberculosis, where you can have a isoniazid resistance to up to 25%, so which is quite high. And in this scenario, we will be having difficulty to have a INH prophylaxis, and definitely rifampicin would be having a difficulty in this scenario. So what the no routine prophylaxis. Most transplant centers do not routinely do a LTBI prophylaxis due to lack of reliable LTBI identification methods, concerns about the drug resistance, and there is high drug resistance rates. Also, India is having, which already I mentioned, that more than 25 or 27% of the global drug resistance TB cases is being contributed by India. So where, and this is most important things which have to remember. Also, there is already the opponent has mentioned that there is increased hepatotoxicity concerns. So what we are doing? So are we benefiting, or are we putting a patient on a hepatotoxicity risk, especially if patient is having a liver failure and without lack of overall mortality benefit? So there is clear cut need of context, need for the context specific evidence, call for the further research, emphasize the need for properly designed studies to evaluate the efficacy and cost effectiveness of the LTBI screening and chemoprophylaxis tailored to South Asian region, the Indian settings, and focus on the active tuberculosis detection, which is need of hour for a patient having renal failure as well as liver failure, and also post transplant patients. We have to identify the active tuberculosis rather than putting up to check for the asymptomatic carriers patients. So there should be an alternative screening strategy. There should be not a routine screening. There should be a alternative screening strategy, like high risk patients. We have to check high risk patients, those who have chance of getting tuberculosis. Then only we have to select that patients to go for IGRA or TST. So targeted screening should be done rather than routine screening. And also there should be an importance of an evidence over the expert opinion. So there should be a robust evidence needed for the LTBI screening procedures and chemoprophylaxis in high burden TB settings. So in conclusion, weighing the risk versus benefit, risk associated with the routine LTBI screening in the asymptomatic donors and recipients outweighs the potential benefits. And there is an urgency of the evidence-based approaches, urgent need for the region-specific research to guide the future practices regarding the LTBI screening and management in the transplantation. So what we recommend is not to have a routine LTBI screening for asymptomatic individuals in the context of high TB prevalence, and there is dearth of evidence of its benefit versus risk. So we should focus on the shift to based on the risk-based screening and active tuberculosis detection. So we'll be open for questions. Thank you, sir, and over to sir.
Thank you, Dr. Shivang, for a great presentation on why one should not think of LTBI prophylaxis. Dr. Akshita, I believe there was supposed to be some pre-polling. So do you want to take the pre-poll just now? And then once the rebuttal is done, then we can just check whether we are managing to flip some votes.
Sure, sir, sure. I'll just share the screen now.
So quite a difficult decision really when it comes to what one wants to do for LTBI prophylaxis. And so that I don't influence the decision of the audience, I'll keep my comments for after the rebuttals come and tell you about what experiences we have had with some patients that we've had with solid organ transplants who we needed to screen also. Some were screened, some were not. As we said, we don't have official, uh, even if you have a protocol which might be from a guideline from somewhere, maybe not everyone follows it. So we are looking at our votes yet, and we have 100% going down to 67 for yay, 33 for nay. That's quite a non-Indian audience sort of an approach to the approval for LTBI prophylaxis traditionally. Of course, that is changing. We've been having LTBI prophylaxis guidelines coming. Okay, we're moving to a 50-50 now. Do let me know when it's over. That's it.
Yes, we'll just
So we are at a 50-50 just before we come to the rebuttals. So Dr. Kriti, do you have something to tell us as far as a rebuttal goes to what Dr. Shivang has presented? Over to Dr. Kriti.
Yes, definitely. The first point I'd like to start with is screening is always done for asymptomatic individuals. That is how screening programs go. And second is we are already dealing with a high-risk population here. We are dealing with a post-organ patients going in for organ transplant. Is my slide visible now?
Yes.
Yes.
Okay. Yes. First, let me go to a systematic review and meta-analysis, as Dr. Shivang said earlier, which even in this study, the TST and IGRA failed to predict active TB. But let me come to the limitations of such studies. Most of these studies provided prophylaxis for patients testing positive for LTBI. Once you do the LTBI screening, if the patients go for LTBI therapy, then they're unlikely to develop TB, active TB later. And these studies then would fail to establish accuracy of the screening tests to predict the likelihood of active TB post-transplant. Lack of data regarding compliance to prophylaxis and results amongst those not completing the prophylactic course. None of these studies randomize patients into screening versus no screening or one test versus other. Follow-up post-transplant is variable, and this is the most recent systematic review and meta-analysis published in the Open Forum of Infectious Disease. Coming to the next point, saying IGRA or a TST will cause financial burden to the patient as well as the country. This is a Japanese study, which is a very systematic study done in. They have divided patients into four the cohort into four groups: QFT, T-spot, tuberculin skin test, and no screening. These populations were analyzed for per person cost, effectiveness, incremental cost effectiveness, and all these ratios were calculated and compared. What is the result? QFT was the most cost effective. No screening was the least effective. So cost effectiveness was not sensitive to BCG vaccination rate, cost of screening tests and treatment. Is cost the problem? No. Coming to patients developing toxicities, this is a study involving a diverse group of population: kidney, liver, and lung, heart, kidney, pancreas, and islet. All these transplant patients were included in the study, including around 200 patients. Amongst these, 189 were initiated on therapy. This cohort included patients who were started on LTBI treatment pre-transplant, and many of them did not complete the whole course before transplantation. They were continued post-transplant also. And in these, 64% of patients completed their transplant. Of course, in few liver transplant candidates, they did the transaminitis led to the discontinuation of therapy. But in 600 patient years of follow-up, there were no cases of active TB. This again goes in favor of LTBI and TB preventive therapy. Should we worry about emergence of drug resistance after LTBI treatment? This again, Dr. Shivang mentioned in his presentation. This is a systematic review and meta-analysis of 6 randomized controlled trials of rifampicin containing regimens for LTBI treatment that reported drug resistance. No statistically significant increased risk of rifamycin resistance was noted after LTBI treatment with rifamycin containing regimens. The studies quoted earlier, those patients that actually received the conventional ATT regimens and then developed MDR or drug resistance and not treated for LTBI. Let me again come back to my primary point. Numbers speak. Post-organ transplant, the incidence of active TB in TB endemic countries like ours is around 8.6%, mortality being 19%, and graft rejection is as high as 33%. If there is any way we can even reduce these numbers and percentages by a small number, we should do it and give the patients a healthy post-transplant life and years as well. I rest my case as such. Over to you. Thank you. Over to Dr. Mihir and Dr. Shivang.
So, a great rebuttal, and we'll move to Dr. Shivang quickly to see what he has to say for this rebuttal as well. Dr. Shivang, any thoughts?
Yes, sir. The ma'am has showed good articles, but mostly are of Western origin. So the thing is, we don't have a much of evidence regarding the Indian settings, South Asian settings. We should know, and there are not clear-cut RCTs or been published or meta-analysis, especially in this kind of scenario. So definitely, we should not look at the Western data and put in the context of the Indian settings. The rifampicin resistance things which already been published in it is from the Western data. So definitely it is of all data are of Westerns. So definitely we need a robust research in Indian settings, and we should think about the Paul Orlis had already said the drug resistance follows the a shadow, a faithful shadow when you use the drugs. So once you administered any antibiotic, and we know about our Indian mentality also, we are not sticking it to the prophylaxis. It is just a prophylaxis. I am not having a TB. So yeah, I can miss the drugs. So these are the practical problems which we have to remember. We have to take care about these things. And rather than focusing on the screening, we have to focus, if we want to decrease the mortality in tuberculosis patients and transplant patients and all, we have to check the early and the atypical presentation of tuberculosis. If we detect it earlier, then only we can improve the mortality. So definitely we need a robust data for this, and we need an active participation from the research perspective. So this is my rebuttal.
So, Dr. Akshita, we can start the polling, and Dr. Kriti and Dr. Shivang, you all can be online. So this is a really difficult topic to talk about as such, and I'll tell you a few cases that we came across where generally you will be referred by the transplant nephrologist or the hepatologist that okay, this is my patient. Probably we need an evaluation because we think he is infected, something that you want to treat for, and eventually you find out this patient is probably dry. You go into a history and you ask, and this is the Indian scenario. This patient who has been treated for MDR tuberculosis. Now he's been treated for MDR tuberculosis. If this patient, let's say, tests IGRA positive, and he invariably does, or MANTU positive, what is it that we want to give this patient? An MDR patient, as per present guidelines, your contacts are supposed to get levofloxacin, or even actually 4 months of rifampicin as per present Indian guidelines. Now, what happens when this patient is actually fluoroquinolone resistant as well, has managed to receive therapy, has got treated, and he comes now with an IGRA positive? How do we want to go about it? Even for that matter, when you have patients who are going on to immunosuppression with your rheumatologists, they come to you with an IGRA positivity with this thing. Do we really know how many weeks we want to wait before we want to initiate the immunosuppression? The British Society for Rheumatologists gives us one guideline. There is another from somebody else. So that's another difficult thought. While Dr. Kriti did show us some research on how they had used isoniazid in your liver transplant cases, again, a little contentious because even when they are not getting transplanted for livers, you do tend to have patients getting hepatotoxicity. So, a completely valid point from Dr. Kriti that immunosuppression is definitely there. You're definitely going to have a patient who's at risk for reactivation, And once he's reactivated, if he has a graft failure, that's a major loss to the exchequer also. So cost cannot be your defining feature always when you're deciding what you want to do. Do not be the patient's financial advisor. You have to look at what needs to be done for this patient, of course. And as Dr. Shivang said, we don't have significant evidence in the Indian scenario, especially when we have such high levels of resistance. If your primary case was never tested for isoniazid resistance, if your primary case was actually a pre-XDR for that matter, when he got treated earlier, what do we do when we are giving prophylaxis to these patients? So a patient-centered approach, you always need to get the patient into the forum of discussion. These are the risks of going on to prophylaxis. This is what we know, this is what we don't know. And also, if you are to get a prophylaxis related reaction, how are we going to manage it? And what are the options that we have if we don't give you prophylaxis and you get tuberculosis? Can we treat it with your immunosuppression? How much modification is genuinely required in your therapy with this immunosuppression? Because you will be juggling your tacrolimus, you will be juggling all of your other immunosuppressants when you are giving them ATT as well. Is this a risk they are willing to take? So we have an Indian audience giving a no for solid organ transplant LTBI screening, something entirely believable, but something that definitely needs to be looked into. Any parting thoughts from Dr. Kriti, Dr. Shivang? I mean, beyond the discussion of this debate, what are your personal opinions about how do you all see patients when you all get solid organ transplant referrals?
Yes, I couldn't agree more, Dr. Mihir, with what you just said. I think that was an excellent closing remark, and I think we should take home the same message that you just gave. Definitely, especially in high drug-resistant prevalence areas, especially places like Mumbai and Maharashtra being the center of drug-resistant infections. We have to keep that in mind as well. And I think whatever you just said, we can take home that message.
Right. And Dr. Shivang, any personal experience or anything that you practice beyond the confines of this debate?
Yes, sir. I am totally agreeing with you 100%. And this is what what we have a real scenario where we don't know what he is having, what he has had a past history, what he has taken, and now what he will have. So definitely, this has to be taken cautiously in each and every patients, not to be as a guideline to check for every patients. So definitely yes.
Right.
Thank you.
Right. Right. So over to you, Dr. Akshata. I think we're at the end of the session.
Thank you, Dr. Mihir. Thank you for making time for this and at such a short notice. And yes, it was an incredible evening filled with very thought-provoking debates and dynamic discussion. And I hope all of you have enjoyed today's session as much as I did. And so we explored from the nuances of choosing the right antibiotic in gram-positive, then gram-negative, then looked at the various pros and cons of the diagnostic tools like Biofire. We did take a deep dive into most pressing issues and controversial topics in the ID today. So I would like to acknowledge all the speakers for making time and sharing their insights and perspectives so passionately. So your contributions have certainly given us all a lot to think about and to reflect upon. A special thanks to our moderators, Dr. Survi Madan, Dr. Deepak Kumar, Dr. Vidya Devarajan, Dr. Vibotak, and Dr. Mehir for expertly guiding through these discussions and ensuring balanced and evidence-based debate throughout. So again, I know we've exceeded time, so I will not take much of your time. And yes, thank you all for joining tonight. And it was a great 3 hours of learning. And I have shared the feedback form. Kindly fill it so that it will help me plan the future sessions. So the next session I'll be having will be transplant ID series, where the first talk will be by Dr. Oriel Manuel, who is from who's a expert transplant ID physician from Switzerland. So hope to see you all until next time. Bye. Have a wonderful weekend.